Good afternoon, everyone. My name is James Telsky, and I'm the chair of the Department of Psychosocial Oncology and Palliative Care at Dana-Farber Cancer Institute and professor of medicine at Harvard Medical School. I'm here today in my role as co-chair of the National Academies Roundtable on Quality Care for people with serious illness. My other co-chair is Peggy McGuire, who's the president and the board chair of the Cambia Health Foundation. I'd like to welcome all of you to this webinar today, and also just to say a little bit about the Roundtable, which is an organization under the auspices of the National Academies, comprised of multiple stakeholders, a diverse group of stakeholders, all concerned about care for patients living with serious illness. And our focus has really been to shine a light on key issues that are relevant to this topic through webinars, workshops, publications, and other communication efforts. And today's effort is webinar is one of 3 in a series on the impact of the pandemic, the COVID-19 pandemic, on serious illness. I'd like to thank all the sponsors of the Roundtable. You can see them listed here in this slide. I will not name them individually, but all of these organizations help to support this effort and have been important partners for us. I'd like you to know that a recording of this webinar and the meeting materials are going to be available on the event webpage, and on that webpage also for National Academies, you can also find more information about the Roundtable. And at the end of every one of the sessions today, we're going to have this opportunity for questions and answers. We hope that this will be very interactive. And we encourage you to put your questions into the Q&A box below, not to use the chat, but to actually use the Q&A box that's at the bottom of your screens. You know, as I think about this topic today, I look back and I realize that in the spring of 2020, our world turned upside down. And for those of us who are working in palliative or other serious illness care, it was a moment of great need, reflection, and value. All the things that we had been working on for so long suddenly were in the front of mind for everyone. The role of family and social isolation, the need for high-quality decision-making in the face of serious illness, the attention to symptoms and comfort in the face of illness that may be incurable, and the importance of high-quality communication in every facet of what we do. Suddenly, those of us who focused on serious illness care felt thrust into the middle of everyone's plans, and our value was apparent in plain sight. Personally, I remember ordering baby monitors from Amazon so we could watch the patients in our COVID palliative care unit without having to spend every minute in the room with inadequate PPE. I remember the frantic family meetings about patients who were rapidly decompensating and the pain of trying to describe the situation to a family member who could only imagine what their loved one was going through. And I'll also never forget celebrating Marge, the 96-year-old woman who was admitted to our COVID palliative care unit, expected to die, but survived her bout with the virus and left the hospital to a cheering crowd. For our department, at least, that interest has not let up. I'm grateful that our work is valued and appreciated. I also wish it had not taken a pandemic to get us there. The COVID-19 pandemic has entirely upended how and where and with whom we do our work. It has created the challenge of new chronic conditions, and we've watched those living with serious illness miss the care they would have received. And it again highlighted the tremendous disparities in the care that we give and our need to do this much, much better. We look forward to exploring these and many other issues in this series of webinars that will be presented over the next several weeks. At this time, I'd like to thank the planning committee that put together this program that was so ably led by the co-chairs, Dr. Susan Wong and Bryn Bowman. I would also at this time like to thank the National Academy staff that do so much of the hard work behind the scenes and without whom this would not be possible. So I'd now like to introduce the Planning Committee co-chair, Dr. Susan Wong, Dr. Wong is the Southern California Chief of the Department of Geriatrics and Palliative Medicine and the Southern California Medical Director of Life Care Planning and Serious Illness Care and the National Lead for Palliative Care for the Kaiser Permanente healthcare system. Thank you, Susan.
Thank you, James, for your comments and warm introduction. It is my great pleasure to welcome you to each webinar of this three-part workshop. We will discuss how the COVID-19 pandemic has both highlighted and exacerbated the challenges in caring for people of all ages with serious illness. The US has lost over 750,000 people to the virus, and countless more have been impacted: caregivers, family members, and healthcare workers. Up to 1/4 of those infected have sought care for long COVID symptoms, memory loss, breathlessness, fatigue. In addition, we recognize that people without COVID also require care for advanced illness, and the strain on our health systems has affected access to treatment for these individuals. As our planning committee navigated the goals of this workshop in an ever-changing landscape, it became clear that there is not a single unified experience for this national tragedy. Health disparities are prevalent. Black, Latino, Pacific Islander, and Indigenous Americans have a COVID death rate of double or more than that of white and Asian Americans. Older adults and people with chronic illness suffer increased complications. Regional variation has been substantial. In recent months, people in rural areas have had a death rate twice as high as people in cities. Communities that are unprotected by vaccination or other mitigation efforts remain at risk. As a result, health equity is a necessary priority in our workshop, as well as a focus on novel programming, workforce, telehealth, and policy levers that will help us prepare for a better future. Also living through COVID-19 as a physician, I have alternated across stages of anxious preparedness, surge crisis, and cautious optimism. One thing I've learned is that recovery is created by people. Communities recover when people choose to commit, to reconnect and rebuild. So this workshop is our call to reflection and shared learning to improve the lives of people with serious illness and those who care for them. Let's get started. Today's webinar will discuss the immediate impact of COVID-19 and the innovative responses that resulted. This session will be moderated by Dr. Judy Salerno, President of the New York Academy of Medicine. Please note that full bios for our speakers and moderators can be found in the briefing book on the event webpage. We will begin with keynote remarks by Dr. Harvey Feinberg. We're incredibly fortunate to have Dr. Feinberg commence our workshop. He is the president of the Gordon and Betty Moore Foundation and the chair of the National Academies Standing Committee on Emerging Infectious Diseases and 21st Century Health Threats. The Standing Committee helps inform the federal government on critical science and policy issues related to emerging infectious diseases and has conducted numerous rapid expert consultations on the COVID-19 pandemic.
Good morning, and thank you so much, Susan. I'm so appreciative to the Planning Committee for this opportunity to speak with you this morning and offer a few kind of context-setting remarks on the history and policy aspects of the pandemic. Pandemics, of course, are nothing new. Pandemics have recurred historically at irregular intervals, spaced usually in decades, sometimes almost in a century, between truly major pandemics. We've often heard with the COVID pandemic, for example, that it is the most severe since the great influenza of 1918, 1919. Pandemics, because they occur with such infrequency, relative to a human lifetime, you have relatively few instances for study, as if the pandemic itself was the object of a scientific observation, and a long time to think about them. This has several consequences. One is that it tends to encourage overconfidence because of long reflection about a very small number of events in terms of understanding, anticipation, ability to respond. Secondly, the long interval promotes neglect, particularly neglect of the public health infrastructure, which is so crucial to being able to cope with a pandemic. So from a historical point of view, while pandemics generally are the result of zoonotic emerging infection, many zoonotic infections do not result in a pandemic. Think back to the first SARS in the early part of the 21st century, and it affected a number of different places. It caused very severe illness. If instead of occurring in Singapore and Toronto, it had emerged, say, in New Delhi and Kinshasa, the world experience with the first SARS might have been very different to what it actually was. And this emphasizes the high degree of uncertainty about the course of a pandemic, as well as the arrival of a pandemic. Who among us could state with absolute confidence what will be the course of the pandemic we're now experiencing, even now, throughout the winter that we're about to face? Is it going to recrudesce, as respiratory infections often do during the winter months? Will the numbers who are immunized and other measures lead to a suppression of disease? Has it played out already as much as it's going to? Or is this virus not quite done with all the tricks, metaphorically, up its sleeve in terms of variants and other developments? How effective will our new treatments be to suppress the development of serious illness? Very promising recent developments among the antivirals. All of this uncertainty, layered on top of the infrequency of a pandemic, makes coping with a pandemic an ongoing challenge. I want to mention very briefly 6 elements in the response to a pandemic from a social, political, national, and global point of view. But the implications are not only global and national, they are also highly local and institutional. The first element is leadership. In any crisis, there is both the demeanor of leadership and the content of leadership. We look to leaders for confident, calm, clear communication, assessments that help everyone understand where things stand and what we are doing. On the substance, you want leadership that is taking advantage of the best available evidence, making sound decisions, taking account of fairness, and most of all, keeping in mind always the welfare of the entire population. Secondly, the importance of science. Science provides the evidence that represents the soundest basis for decision-making in the face of a pandemic. And of course, this connects directly back to the question of leadership and the ability of leaders to make sound decisions. To what degree are they relying on sound science? In the case of the United States, I hardly need to remind this audience of the ways in which our national leadership early in the pandemic played down the seriousness, dismissed the likely consequences, provided false reassurance, and touted treatments which proved to be ineffectual. So leadership and science are two of the key grounding important foundations for the third element, which is public trust and understanding and action. Trust, understanding, and action on the part of the public are critical in any successful response to a pandemic threat. And in this respect, we can look to some national cultural attributes to think about the difference in public confidence and response. Public trust in many leadership authority figures, sectors in the United States has been eroded over time. Public trust is always at risk. Compare the Canadian sentiments about good government, order, and peace as contrasted with our American ethos of life, liberty, and the pursuit of happiness. Each of those sentiments, respectively, appear in the founding documents of each country. In the United States, we started with immunization at a more rapid pace than either Canada or Australia. But over time, because of hesitancy, unwillingness to take the vaccine, lack of trust, those countries have higher proportions of their adult populations immunized, even than the United States, where the most effective and highest benefit to risk ratio vaccines were created. So public trust has implications from the beginning throughout the pandemic. Fourth is the element of sound strategy. Having good leadership, depending on science, gaining public trust has to be translated into a program of strategic response that looks to care for those who are ill, interrupt the spread, and put in place the conditions that will minimize consequences over time. Strategically, it is very difficult to accomplish a national response in a country like the United States, where sovereignty has never fully been resolved between the national government and the individual states. We made this, I think, purposefully ambiguous in the founding documents in order to gain participation. But over time, where does authority rest when you need to respond in an emergency, urgently, and with consistency? This was a terrifically challenging problem when we found ourselves in situations where individual states had disparate and still do have such disparate approaches, where they were competing with one another for the acquisition of necessary protective equipment, where they had so much to do in common and only found it possible to do it separately. So the United States begins in any national crisis with a challenge on coherent, consistent strategy. Managing that foundational challenge is a critical part of successful response in the future on the part of an American response to a pandemic. And this problem, which we see reflected nationally in the differences of authority between states and the national government, is only amplified multifold when you consider the global response requirement and the variety of interests, rivalry, and sometimes conflict among the states of the world, the nation states of the world. And so strategy is a great challenge and tremendous importance. Fifth, you have to have adequate resources available to make the strategy real. And this was a serious shortcoming on the part of the American response early on. I needn't remind any of you who was in the midst of caring for patients in the first months of this pandemic, how stressful the absence of adequate protective equipment and basic supplies. Yes, we did not have a lack of oxygen as in India, but compared to the resources, the ability, the amazing amount of human capacity in our health system, the absence of adequate resources at that level proved to be problematic and still not a source of pride for the United States. By contrast, the country did lavish tremendous resources, billions of dollars on the development of the vaccines, and also, perhaps tardily, but eventually, billions of dollars in the development of effective, convenient, rapid, and home-based testing, which is increasingly available. So resources are critical as the fifth component after strategy. And finally, ability to implement on the ground. This takes leadership of a different sort. It benefited tremendously from the long history of volunteerism and readiness to pitch in that has been characteristic of the United States ever since the visits of de Tocqueville. Here, people rallied, but systems that are designed to function under normal circumstances and to respond to a pulse emergency. Hospitals with routine care, there's a major fire, storm, other catastrophe, we can respond in a pulse way to care and manage for that influx. A pandemic is serious, sustained, and disruptive. And systems that are set for routine and for pulse emergencies can be overstressed and disrupted, as we experienced, when the impact of a problem is long-term, severe, and emergent. So this set the stage for the context of your discussion on the care of patients with serious illness. I would say there are 5 layers at least to that implication, and we've already heard them alluded to in the introduction. The first directly are the patients with serious illness of COVID, the acute and the long-term consequences of this infection. Secondly, there are the disruptions to the care of other patients with serious illness and the adaptations that are required in order to manage the care of all patients during a time of COVID. Third, there is the stress on healthcare providers and healthcare institutions and the healthcare system that I have already alluded to. But the strain of continuous obligation, of uncertainty, of lack of knowledge early in the pandemic was especially stressful. I can recall a number of the communications early on about the observations of seriously ill patients with multi-system failure, not simply consequent to the respiratory disease, but directly affecting other systems, the cardiovascular system, neurological system, renal system in patients, and figuring out strategies that would improve their care. The stress on professionals and institution, number three. Fourth, the disparities in care that have been exacerbated and revealed as a severe deficiency in our healthcare system is another consequence of COVID on serious illness care, but truly on all illness care. And finally, COVID also disrupts the larger social context and capacity to provide necessary social services and support systems for families and abilities of communities to function and economic disruption, all of which complicate the ability of our healthcare system and health professionals to provide the care that is necessary to our patients. So we have severely ill COVID patients, the care of other patients with serious illness, the disruption to caregivers and institutions, the exacerbation of disparities, and the underlying social disruption, all of which make this discussion today and in the subsequent workshops so important in taking stock. What have we learned from COVID and about COVID? How can we take those lessons and apply them in a consistent and effective way to improve the care of patients with serious illness? It's a wonderfully important mandate. I wish you every success in the deliberations, conversations, and exchanges today and in the future workshops, and look forward with keen interest to learning the results. Thank you all very much.
Thank you, Dr. Feinberg, for this excellent presentation. And what a great framework we now have as we launch the webinar series. And as we delve into the issues for assessing the lessons of COVID for caring for people with serious illness. And we'll have the opportunity to continue this conversation with Dr. Feinberg in the Q&A session that will follow after our next speaker. I'm now pleased to introduce Dr. Jared Carroll. Dr. Carroll is the Associate Program Director for the Kaiser Permanente Geriatric Medicine Fellowship, and he also leads the consultative service for memory assessment and care at KP. And he's going to share with us some of his reflections on his personal and professional experiences during COVID. Dr. Carroll.
Good morning, good afternoon, everyone, and actually good morning from the West Coast. Thank you for the introduction, Judith, and for the opportunity to participate today in this much needed conversation about learnings that emerge from the challenge of the pandemic. In my role as a geriatrician in the Memory Evaluation Clinic, I not only take care of the patients, but also work directly with their families, helping them navigate the changes and challenges that come along with progression of underlying dementia. Similarly, we know that in taking care of the seriously ill, while the patient remains at the center of our conversation, we also play a very valuable role in discussions with families, often standing in the gap for the families, explaining decline, managing expectations, and coordinating care throughout all the challenges. COVID was an unrelenting challenge, and it required, or in most cases, forced us to change. In fact, the one word that has been at the center of all learnings from COVID for me is change. Change in our daily routine, change in how we see patients, changes all around us. Therefore, for the sake of framing my brief discussion today on my lived experience, I will utilize the word change as an acronym, looking at each letter as a guide for things that I learned and that were revealed to me while taking care of the seriously ill during COVID. Okay, let's go. Change. The C in change undoubtedly means communication. Beginning in early 2020, we witnessed the rapid rollout of the virtual platform. Yes, we had some footprint of a virtual platform prior to COVID, but COVID had quickly paralyzed our normal routes of communication, impacting the daily routine and environment, which is integral to the successful management of dementia in my clinic. Changing communication techniques, however, was no easy task in this patient population. As we know, that there's not always a strong grasp on technology by not only patients, but their families. We had to adapt. Dementia and many other progressive conditions continued on, and in most cases, continued on unchecked, despite COVID appearing to put everything around us on hold. Within the clinic, we found out patients lost caregivers, lost daycare programs, lost routines. We had to adapt quickly. In the clinic, we launched a proactive outreach initiative that was led by our social worker and the case manager to reach out to patients and their families and help them try to navigate the challenges of 2020. Furthermore, as the health system focused energies on addressing and trying to contain the virus, I was moved from the clinic to the nursing home setting, which had been disproportionately impacted by COVID. It was there in the nursing home setting that I was able to witness even more of the detrimental impacts on communication. As a part of the lockdown, as we know, nursing facilities closed to visitors. However, in locking people out for the patient's safety, we locked the patients in, which impacted them physically, emotionally, and mentally. They felt like prisoners. They felt like hostages. And I remember the first time a patient said that to me, I was overwhelmed. But I spent some additional time with him, explained to him why we were taking the measures that we were taking. And I don't think he quite understood it that first day, but over time, I think he grew to understand we were committed to his health. This was difficult, but we had to do it. We were slowly able to transition to the virtual platform in a nursing facility, but it took some time. So in the interim, families waited with bated breath to hear the daily update, hanging on our every word during very important discussions, often having to participate in life care planning and life and death decisions via phone, even when COVID was not the primary concern. Now, we know the importance of nonverbal communication, but in this situation, often we lost that ability. There was no chance and opportunity sometimes for the patient's family, their advocate, to stand at their bedside and hold their hand during these discussions. So we as providers had to function as the connection, the link to provide communication. The C in change for me is for communication and how even more important it became. That brings us to the H in change. The H in change for me represents hope and health. H for hope in the sense that as the spread and impact of the virus continued, we wanted to look ahead to its containment with hope for the development of a successful vaccine. The conversation in a way shifted from one about when this would be over to when would we be able to establish a new norm, accepting that we would have to live with COVID, but hoping that the vaccine could provide us some comfort. There was hope for health. There was hope for healing. Hope in health actually makes me think of one of the many patient encounters that I had while taking care of patients in a nursing facility. There was a particular patient whose fear had literally paralyzed her and her family. She had been having worsening renal function for some time and other health declines, but had repeatedly refused transfer to hospital for fear of getting COVID. It was in this moment that we had to have a very important conversation about hope and health. See, the public saw our intense focus on COVID during 2020 as our sole focus, but we had to remind them that that was not our sole focus. We still played a very vital role in general health and management of other conditions, other serious conditions. So we had to think outside of the COVID box, even when the community and the world thought that was our sole purpose. Building hope and faith, hope and health was actually a success in this case. We were able to develop a plan with the patient and family in mind and successfully transfer her to and from the hospital. She was eventually started on dialysis, which is a life-preserving technique. There was hope. There was hope that a vaccine was coming and hope that we as providers could still be in the business of health and healthcare, even outside of COVID. We leaned on hope. H in change for me is hope and health. The A in change is for advocacy. Advocacy for the aging and seriously ill became even more important during the pandemic because we knew that the pandemic disproportionately affected the chronically ill and those over the age of 60. This vulnerable population faced a double risk, first from coronavirus itself, and secondly, from the effects of isolation on their physical and mental health. Tying back to communication, many patients in nursing homes lost their bedside advocate, so we had to be their advocate even more. Advocacy also included proactive outreach programs that was employed by many clinics, including mine, to help monitor chronic disease and even completing home visits if needed. Additionally, we realized that a lot of the seriously ill are in home or in a facility. So they're somewhat tucked away from the main view of healthcare. So we had to advocate for their care by making sure that they were considered when we were eventually rolling out the vaccine. I remember partnering with my chief at the time, Dr. Wong, and developing a list of homebound patients, making sure that we kept them in mind when their time came. It was important for us to stand as advocates for the patient and continue to grow the patient, doctor, and family relationship. The A in change was for advocacy. The N is even more personal for me. And it may seem to veer a little bit off topic, but it was at the center of my learnings from COVID. N in change is for nurture ourselves. As the virus plagued on, we saw weeks become months and 2020 become 2021. We saw the impact that it had on us. We were focused on taking care of the patient in front of us, but often not realizing the help needed from the person to our left, to our right, and the person within. We must, guys, nurture ourselves. If we don't take care of ourselves, we cannot take care of anyone else, including the seriously ill, which entrust us. The G in change is for the greater good. What was initially thought to be short-term changes of wearing masks, adapting to quarantining and social distancing for maybe a few weeks, maybe a month, maybe 6 months, eventually became the prolonged conversation and a huge ask that weighed heavily on us, everyone, including us. These protective measures we know saved lives, including the ones that we take care of, the seriously ill. We had to focus on, there was no I in team, no I in we, no I in success or us in general. We had to cooperate and realize the importance of focusing on the greater good by modeling that what we wanted our patients and their families to follow. The last letter in change for me is E, for equity and empowerment. As Dr. Feinberg mentioned, as the pandemic continued and spread its impact, it further exposed inequities that we were aware of. It also highlighted that health equity is still not a reality as COVID-19 disproportionately impacted certain races and ethnic minority groups. As an effort to address these inequities, I use E for empowerment, using virtual platforms to connect with patients, families, caregiver groups throughout the country in an effort to address concerns like vaccine hesitancy. We had to stand in the gap. We had to realize the impact that we play in the role that we play. So to me, to summarize, in my lived experience, change is the only constant in life. We had to make a lot of changes during the pandemic. Changes in communication, hope in health, attention to advocacy, understanding the importance of nurturing ourselves, focusing on the greater good, realizing the impact that it had, and a focus on equity and empowerment. I look forward to continuing to be able to provide care and support to those that need it most, including the seriously ill. Thank you.
Thank you so much, Dr. Carroll. That was a really moving presentation, and I love those that acronym. So now we're going to move to our Q&A, and I'll ask the audience to post any questions you have in the Q&A box at the bottom of your screen. So we'll bring back Dr. Feinberg and Dr. Carroll, and we will be joined by Bryn Bowman, who is the co-chair of the Planning Committee and the CEO of the Center to Advance Palliative Care at Mount Sinai in New York. So thank you all, and let's get to the Q&A. First, I want to reflect on the word disruption that came up during the presentations. And we've talked over many years now about the need to be disruptive in healthcare. But the pandemic certainly was a disruption that we didn't expect and threw a lot of curveballs. So I want to ask each of you, what changes to care brought about by our response to COVID are really durable, that we should consider adopting and as a way forward as we think of positive disruptions in healthcare?
Who would you like to start, Judy?
Dr. Feinberg, go ahead, Harvey.
Well, I'd really love to hear what others have to say too on this. You know, there's a big difference between disruption that happens to you and disruption that you impose on others. And of course, the disruption we seek in healthcare is frequently a disruption that is thoughtful, important, and intentional. This disruption was none of those things. At the same time, I'll just mention one area of practice that I think has really revealed itself in a much more powerful and useful way, and that's telemedicine, telehealth. The ability to interact with your clinicians in a meaningful way at a distance. It's not the same as the laying on of hands. It's not a substitute for direct interaction, but as a supplement, a complement to care that engages with the patient in a regular, reinforcing and comforting way. I think telehealth is one of those disruptions to our healthcare system that is likely to have durability and value.
Thanks. So can I hear from Bryn now? I know you have a lot of change in the past.
That's right. We've seen a lot of change, a lot of disruption, like you say, Judy, in the palliative care field over the last year and a half. And I could not agree with you more, Dr. Feinberg, about telehealth. What we saw in palliative care was really rapid evolution and a lot of creativity about how best to use telehealth to extend the scarce resource in many organizations that the palliative care team is. And so whether that meant helping patients with COVID or other serious illnesses safely shelter in place and have touch points with those patients, whether that meant beaming palliative care specialists into, for example, the emergency department or a nursing home to be able to talk with patients about their goals of care. And in other cases, helping to balance palliative care capacity across multiple locations in the health system using telehealth. And I think all of those things are things that can be adapted and integrated over the long haul with telehealth in the field. The other thing that your question makes me think, Judy, and this isn't necessarily specific to serious illness care, though I think probably the needs of those of us in our field who are doing serious illness care are particularly acute, is a true meaningful focus from healthcare employers on the emotional well-being of their staff. That sort of business as usual solutions and resourcing of that priority are not going to be good enough coming out of this pandemic. And so I think I hope that disrupts, how healthcare organizations think about that. And then the third thing that occurs to me is the clinical relationships that were disrupted, but in many cases strengthened, or new clinical partnerships that developed during the pandemic. And I know we're going to hear about a lot of examples of new clinical partnerships throughout the rest of today and subsequent webinars. But one fact is that in the field of specialty palliative care, consult volumes had gone up for teams across the country by the fall of last year, and those consult volumes have stayed up despite the fact that in many areas COVID case rates have gone down. And I think that speaks to the value of having access to those teams during the pandemic, and the perceived value of those collaborations that endures beyond the pandemic. So I think we have to think about what it means to resource palliative care teams to be able to provide services to a larger number of patients.
Great. Yeah, that was certainly the case in responding to rapidly changing needs. Jared, could you talk about maybe how this reflected in changes in your clinical practice as well?
Yeah, so I would definitely agree with Dr. Feinberg and Brent Bowen as well about the rollout of the virtual platform. I think that's definitely here to stay. We are able to see patients where they are. And when we utilize this opportunity to see patients where they are, we actually learn so much more about them, understanding where they are, other obstacles that may be present in the home setting. And we're able to peer into their everyday experience. Additionally, I agree with Bren that there was a huge growth and attention on the caregiver and the providers. And I think there was a much needed focus, because as we were seen, we were always seen as supermen and superwomen taking care of patients and families, but we saw the harmful effects it had on our mental and physical health. And so we had to take a step back, and we're seeing a renewed interest by health systems throughout the country being attentive to the care needs of those providers, because we have to take care of each other in order to truly be able to take care of others along the way. So I would say the two things that definitely demonstrate durability is the focus on telehealth, as Dr. Feinberg mentioned, and using that moving forward so we can see patients wherever they are, either in clinic, and have a quick visit via video. And it actually provides more comfort to the patient at time as well, once they get used to it. And then taking care of ourselves along the way.
Great. Well, we have a question that came in from the audience about the Roundtable's operational definition of serious illness. And maybe, Bryn, you can address that.
Yeah, it's a great question. How we define serious illness is in this workshop is a life-limiting illness that negatively impacts quality of life and function, or excessively burdens caregivers. And so the combination of a diagnosis of COVID or of COPD and unmet needs that really start to bring down quality of life for patients and families.
Great, thank you. We all talked about the real-time learning, or as some of us referred to it, as learning on the fly, as the clinical situation changed so rapidly, and as did our learning. But what have we learned perhaps from that experience that will help us in the education of health professionals going forward. Are there lessons learned about this that should influence how we teach? Harvey, would you like to take that one?
Gosh, you know, there's so many challenges for professional education, but I would just mention the pandemic to me has reinforced the value of interprofessional education. You know, the experience of co-care between nursing, physicians, respiratory, all of the other support and types of caregiving is so manifestly central to the care of patients in a pandemic that it reinforces to me the value of interprofessional learning that would prepare and make more effective the interprofessional care on the floor, in the ward, in the nursing home, et cetera. So I would just point to that one aspect of medical, nursing, other professional education as something that the epidemic to me has elevated in significance and relevance to the fully prepared health professional of the 21st century.
Yeah, and that certainly put palliative care teams front and center with an interprofessional approach. Jared, do you have any thoughts on that as running a fellowship program?
Yeah, so I would say we've renewed our interest in wellness as well, taking care of the fellows, and also I think COVID itself highlighted inequities in care, and so I think it brought that more to the forefront, because often when you're learning, whether you're in a medical school or in a fellowship program or residency program, you're so focused on learning more about, you know, what's right about the body, what's wrong about the body, and how we can address it. But often we don't spend as much time talking about those social determinants of health. And I think if nothing else, it really highlighted that we have to appreciate those variables as well. Housing, where people live, how they interact with the health system, understanding that there are differences along the way. If we do not train trainees to be able to appreciate those differences, then they will not be truly empathetic providers to take care of those patients. So you have to approach each patient as an individual and not see one 80-year-old as all other 80-year-olds. They have different resources, they come from different backgrounds, different situations, and different experiences that may impact even their decisions. So we have to be able to listen to the patient and know where they are in order to truly be able to provide care. So I would say a focus on understanding equity and our attention to equity. That is something that we're trying to infuse into our program, as well as focusing on wellness of the provider.
Great, thank you. There's a question that came in from the audience about fee-for-service in this setting. Now, fee-for-service seems extremely inconsistent with delivery of care for complex and persistent episodes of care, such as COVID and long COVID. Can you comment on this and describe any acceleration toward dominance of episodes over events? Very challenging issue. Anyone like to take that, Bryn?
Yeah, I can start, and I'd love to hear what the others have to say about this as well. Appreciate the conversation or the question very much, because I think that the person who wrote this question and is right that fee-for-service is pretty poorly matched to the needs of patients who have medical illness and complex needs over time. And you know, one example of this is thinking about exactly what Dr. Carroll just mentioned, the need for us to take a national focus on the social determinants of health, and make sure, for example, that patients are connected with social work expertise or community service agencies that could support patients and families. Now, that kind of care is harder to do and harder to pay for under fee-for-service medicine. So I think when you look at examples of organizations and entities that are leaning more into value-based care or have capitated arrangements for the care of patients with serious illness under a health plan, that's where we start to see some of these flexibilities that allow for adaptive clinical relationships with very sick patients over time.
Anyone else like to respond to that?
So I would agree with that, what Bryn was saying as well. I think while I don't necessarily work in a fee-for-service area, working here at Kaiser, I can see how it can definitely be a challenge when we have patients coming in and out of the system multiple times for different symptoms. Of course, this is not anything that's new, but I think we're just seeing it. We saw it at an increased amount during the COVID pandemic as patients were dealing with long COVID. And also thinking about the delays in care. So when we think of the COVID pandemic, we often think of patients with COVID, but realizing that we have so many patients that did not have COVID, and we're seeing the effects of that now. We saw that about 90%, I think it's about 90% of patients delayed important cancer screenings during that year. And as a result, this will actually increase our numbers that we will have to take care of the seriously ill because there will be delays in care, delays in diagnosis. And so we can see how repeated visits and things of that nature can actually negatively impact the fee-for-service world. And it doesn't necessarily appear to be appropriately resourced to address those concerns.
Maybe I'll just add a word, Judy, because I agree with everything that Drs. Bowman and Carroll have pointed out. Deficiencies in the fee-for-service system did not arise in the COVID pandemic. They've been longstanding and clear to many over a long period. But like many other things, including inequities in care that also were longstanding, they were exposed and they are heightened as a problem when you're dealing with more seriously ill, long-term need, comprehensive care patients. And when we think about the goals of care, which is compassionate, continuous, comprehensive, really putting the patient first, there's so many ways in which the incentive structures embedded in a fee-for-service model works contrary to that ideal. And that is a serious worry. I would just observe from a practical point of view, this has always been a very difficult area to rectify and correct. And one key in the future may be separating the ways in which patients pay and the ways in which some subsets of clinicians, surgeons of certain types, for example, and others may be compensated or incentivized. So if we separate the way you pay in from the way the system pays out, I think that's perhaps one wedge that we could use to make the payment system more compatible with the real goals of patient care.
Another audience member noted about PACE models, that PACE participants have been reported to have very low rates of infection and death. And so what is it about perhaps the capitation in a very seriously ill older population across many settings? Are there adaptations that we might use to illuminate more useful strategies going forth in the future? So I think that, you know, that really speaks to another question about what are the research questions that this experience has pointed to, that where do we need to invest in looking more closely at some of these issues and to get really solid learning that we can apply in a scientific manner to the future of healthcare delivery.
I would actually venture to say I have a friend that actually works in a PACE system, and she mentioned that their numbers were much lower. And I think one of the reasons is the connection that the PACE participants felt with their providers and their team, because it appears to be a smaller group. And so they felt more connected, and they felt as if they truly had a medical home. So they felt as if they can the providers were able to get quicker buy-in by the patients and the participants, whereas in larger systems, it was very difficult with our messaging in order to communicate at times with the patients and their families. So I think one of the reasons that PACE may have been more successful, some PACEs may be more successful, was because they were able to quickly transition, keep patients in their home, kind of shut down the daycare centers that they organize and quickly transition. And I think that allowed that buy-in that they already had in the relationship. It highlights the importance of having a medical home. And it highlights the importance of having a director that's truly connected and connected to the patients and their families. Because if we get that buy-in, then they will model our behavior. They will see what we're doing and hopefully actually improve their overall health.
Great. Other research questions that come to mind?
Well, maybe I'll just add a general point on the research question, Judy, because I think there's another lesson that's so important that comes from dealing with a new, rapidly moving, dynamic situation of a pandemic with new approaches that are tried all the time, different drugs or other interventions that are touted as helpful. All of this speaks to the importance of pre-positioning the protocols, networks, templates for clinical as well as public health real-time research that would, in a scientifically reliable way, gain evidence, not just anecdotes, about what does and does not work. And so as a general lesson, I would say that the importance of prior established research networks ready to implement protocols, ready to collaborate on data sharing, ready to produce results that would inform with science as opposed to speculation. I think that's a really big lesson for research in the pandemic.
Now, does that reflect in some way on what you noted as our historic neglect of a public health infrastructure?
Yeah, it's all part. It's part of that same picture, isn't it? It is the out of sight, out of mind problem. It is the confusion of plans with preparedness. Plans are not preparedness. Preparedness requires a degree of readiness, on the ground resources, adequate equipment, real tests through simulated experience to demonstrate what the weaknesses are, and the pre-positioning of these kind of networks for both public health community-based investigation as well as clinical. All of that is part of the same problem that you described.
Yeah, certainly a lot to be learned there. I'd like to ask Bryn about a little bit about the functions of the palliative care team during COVID, and particularly navigating what matters most to patients, thinking about goals of care, and how you do this in this kind of setting where there was a disconnect between being able to talk to the patient and the family in such a profoundly disjointed way. And so how did we overcome that, or did we?
A great question. CAPC issued 2 surveys to palliative care programs throughout the pandemic. The first was in May of 2020, and the second was in January and February of this year. And what we wanted to know is basically the question you just asked, Judy, is how were palliative care teams adapting their service delivery in response to the pandemic? And what was the impact of that work for patients and families, for referring colleagues, for organizations? And what we learned is, one, what we've already said, that almost every palliative care program had rapidly scaled up their use of telehealth, whether it was to care for patients with a pre-existing serious illness or be able to be more places at once supporting patients with COVID. But Interestingly, 3/4 of palliative care programs also reported to us that they had started new interventions or services to address the emotional well-being of their non-palliative care colleagues. So that was work that palliative care teams were owning and again, innovating around. About the same proportion, about 3/4 of palliative care programs that responded to us said that they were leading the efforts within their organizations to make sure that COVID patients were able to talk about their goals for care. What is interesting is, so I said 3/4 of palliative care programs. We also heard a lot of stories about palliative care teams who very quickly started teaching other colleagues, other clinical colleagues, to have those conversations. Maybe colleagues who'd been redeployed to other locations because their business as usual wasn't happening in the middle of a pandemic. And so back to your question about education, there was a lot of real-time education in core palliative care skills, like how to talk to patients about their goals of care or how to manage shortness of breath. And I think we really learned from those experiences that talking about goals of care or managing symptoms should be part of the core skill set for any clinician working with patients with serious illness, and not only in the purview of palliative care teams. So that's one lesson I hope we take away. Other innovations from palliative care programs, many expanded their presence in the emergency department and in the ICU. So back to those new clinical relationships, but also how the integration of palliative care services was applied in those settings. And so a lot of rapid response, quick creativity. And the last thing I'll say on that is 60% of the programs that responded to us said that they had worked with their organizational leadership to design the crisis response strategy in the early days of the pandemic. And I think that makes a lot of sense because palliative care teams are expert at acting in an environment of uncertainty to relieve suffering and help patients cope, and help support patients and families through really complicated decision making. And that was what was required, particularly in the early days when we knew much less about successful interventions for COVID patients. So I don't think it's an accident, but something again to take note of into the future.
Thank you. You know, it's interesting because there was a question that came in about long COVID and the emergence of long COVID, and perhaps thinking about this as serious illness care that we will have to manage in the future. And on many, many levels, there are some people who are retiring early, for example, based on long COVID. But, you know, certainly we haven't been in this pandemic long enough to know how long it will last, but the communities of people with ME and other chronic viral conditions that have sustained impact on quality of life also are dealing with long COVID. And, you know, so we have a lot there that we can perhaps use the principles of palliative care to help with. And it's been noted by some that some of the long COVID programs are dealing with pulmonary and cardiac care and rehabilitation, but not the whole person care that is requisite in serious illness care. So would you have any thoughts on where we might be going with long COVID? Anyone? It's a tough one.
I would say I think this belongs in the category of your last question of an area where so much more research is needed to really understand what patients are grappling with, how long we can expect it to last, and what is the best way to support families. There's so much that's unknown right now.
And also I would venture to say, so I'm seeing it, I'm back now in the memory clinic taking care of patients there. So I'm seeing a lot of the changes as a result of its impact neurologically or from a memory standpoint. Additionally, I think it's important to comment on long COVID, the long haulers. Yes, it is for patients that still have COVID, but also checking in with the patients and families that have lost patients along the way as a result of COVID. So I think if we don't check in with those patients And we realize the impact that it can have on their overall health if we don't really check in with that patient and truly address their mental decline and their emotional decline as a result of this truly long experience. Then we will definitely have more effects long term on even those patients who did not have COVID, but were directly impacted because of the role that they played in the person's lives.
Great. There's a question that came in noting that Dr. Feinberg emphasized training among healthcare provider categories. And the question is, might we think about training the substantial numbers of leaders in each healthcare category in such topics as urban planning, community organizing, housing, and economic policy? I presume addressing the many, many social determinants of health and a growing list of them. Harvey, would you like to comment on that?
You know, I've always thought one of the wonderful opportunities of a career in the health professions is the combination of intensity of experience with individual patients and breadth of opportunity to work on health and health issues, whether within an institution, across a health system, or more broadly grounded in the social determinants that are so critical to affecting health. I think we need the spectrum. We need those who are going to devote their intellectual and professional lives to doing exactly what the questioner is implying, who will be the bridge builders between the social and policy worlds and the clinical and patient care worlds. And we need those who are going to be expert in just a single chosen area, whether they are the epidemiologist or the intensivist. It's just the depth of confidence and leadership that they can exert in that way. I'm a big believer that leadership emerges not from role, but from action. It is not the formal authority that anyone brings to a situation that signifies their leadership. It's what they do in any role to bring others to do things that are necessary and require working together and inspire people to do more than they would otherwise do. So we need leaders at all levels, and we need that whole spectrum of expertise and talent in order to really make the progress on health as well as patient care that everyone deserves.
Great, wonderful comments. So I would like to ask in our last 2 minutes if each of our panelists has any final thoughts before we move on to the next session. Maybe start with Jared.
All right, I would say my final thought is really just understanding that while we appear to be turning the corner on COVID, we still have a lot to learn from it, and learning about how the medical system and the health system can adapt to address the changes. And that's why I wanted to use change as an acronym to realize what we went through for 2020 and some of 2021. I think that overall, we played a very valuable role in the care of the seriously ill, and we tried to adapt to take care of them. And I think all of the measures that we took, we can learn from those and continue to grow so that, as Dr. Feinberg mentioned, when the next pandemic comes, hopefully we will document these lessons. And so we can help the next generation of providers to be better prepared.
Thank you. Bryn.
Yeah, I think what I take away is, palliative care teams have been able to adapt really quickly and flexibly during COVID-19 to prevent or address as much suffering as possible, but with acknowledging the reality that in a lot of organizations, those teams are very small or perhaps don't exist. And so the patients served by those organizations did not have the benefit of those services, nor did the treating clinicians who were not able to lean on palliative care colleagues. So I think we have to think about what that variability in access and preparedness means coming out of COVID-19.
Great. Final word from Dr. Feinberg. Harvey?
Well, thank you, Judy. This has been such a wonderful opportunity to hear from our colleagues and great questions. Maybe my final thought would be learning while doing can be empowering. While we are caring for patients, if we keep an open question always, how do we learn enough to do better? How do we learn more? How do we master this situation? It can be a feeling of tremendous power in a circumstance that can sometimes seem overwhelming. So I would say keeping an open mindset toward learning while doing, it can be empowering.
Thank you all for such an engaging conversation. And I look forward to the rest of our webinar. Turning it over to you, Susan. Thank you.
Thank you, Judy.
All right. I love that learning while doing can be empowering. That's definitely a take-home point for me. I do want to thank you, Dr. Salerno, Feinberg, Carroll, and Bryn for our thought-provoking discussion of our challenges and opportunities looking forward. Now I'd like to turn our attention to session 2, which is focused on early innovative responses to the pandemic. And I'd like to introduce our moderators. We have 2 moderators for this session. Lori Bishop is Vice President of Palliative and Advanced Care for NHPCO, National Hospice and Palliative Care Organization. And Karen Bullock is Professor and John A. Hartford Faculty Scholar and the Head of Department of Social Work for North Carolina State University. So I'll go ahead and pass it to you, Lori. Thank you.
Thank you, Susan. I'm excited that we're going to start this session with a brief video montage showcasing examples of several innovations that allowed for high quality care for people with serious illness and their families during the early days of the pandemic. I'm not going to read the names of our montage participants, but you do have a list of their information in your brief.
My name is Terry Maxwell, and I am the General Manager and the Chief Clinical Officer for Turnkey Health, a CareCentrix company. And we provide home-based palliative care as a member benefit for health plans and provider organizations in 5 states, including some of the hardest hit by COVID. We really pride ourselves of going out into the home to meet with patients and their caregivers to discover what's really happening inside that home, ranging from problems of food inadequacies to housing insufficiencies or other concerns, such as social isolation, caregiver fatigue, and depression. So getting to know people in their homes really, we believe, helps to establish trusting relationships, critical for discussing goals of care and advanced care planning. But like many, on the second week of March of 2020, we had to suddenly halt all of our home visits. And we were really concerned that that was going to interfere with our ability to complete advanced directives and document goals of care. However, our teams did a great job by pivoting to virtual visits. And now over 98% of all of our enrolled patients do have their goals of care documented using the Serious Illness Conversation Guide. And over 85% of all of our enrolled members have an advanced care plan completed. And I'd like to share a quick story of a patient who wanted to do her goals of care documentation and wanted to do it with all of her children and her provider, but couldn't do it during the pandemic. And so one of our social workers, Maria, arranged using Zoom to get her physician, all of her adult children, as well as the patient, all to meet to go through the Serious Illness Conversation Guide, goals of care, and then set up a subsequent Zoom meeting with all of them to go through, except for the physician, to go through the advanced care plan. She actually brought that advanced care plan to the patient's home so that the patient would have it with her, and that, led them through the whole advanced care planning process. And then after that was signed, came back to the home, had the patient leave it in an envelope outside the door and picked up a copy to take to the patient's provider. So I think this just shows a great example of kind of the ingenuity and the creativity that was required and continued to be required during the pandemic. Thanks for letting me share.
As COVID-19 cases began to increase and to affect young adults across the DC metro region, Children's National Hospital quickly realized we needed to be prepared to care for new patient populations. We all remember that early on in the pandemic, it was thought that COVID-19 was a disease of the elderly, but this didn't last long. With the increase in COVID-19 patients, adult hospitals began to reach capacity and resources were strained. Children's National Hospital proactively reached out to DC Health for approval to expand the upper age limit for admissions and to care for young adults with COVID-19. Soon enough, patient referrals from adult facilities started coming our way, including some for the most severe cases requiring heart-lung bypass.
Our nurses already had the general competencies to care for young adult patients in some of our specialty care programs. We used this as a starting point to develop a curriculum that would ensure all nursing staff could confidently care for patients in this age range. We needed to develop an education program specifically to care for COVID-19 adult patients. As assessments were done in collaboration with nurse educators, critical care providers, pharmacy, and respiratory therapy, the resulting curriculum included the following: a review of age-specific competencies, an oxygenation module, a review of advanced cardiac life support and the ACLS algorithm, as PALS is the standard in pediatrics. And finally, we included a safe medication module. This was very important because in pediatrics, weight-based dosing is used, and adults, we use unit-based dosing. We also implemented a drug adult library on our smart pumps. These pumps were clearly labeled to prevent mismatch errors.
We came together, hundreds of staff, to complete this quickly and efficiently, and we did it in time to accept all of our adult patient referrals. We took great care here of every single one of them, and we're proud of our work in service to the community.
Hi, my name is Megan Weaver, and I'm a pediatric palliative care physician and researcher in Nebraska. Because our patient population is primarily rural, we had, prior to COVID-19, started to offer families telehealth support and longitudinal care when they were enrolled in home hospice. This also supported home hospice teams who were used to caring for adult patients. We did a warm handoff by being present with the family and the hospice team at time of rural hospice enrollment and remained available for hospice interdisciplinary care meetings and in-person home visits virtually. When the pandemic hit, our patients had further need to remain at home, and many had the desire to remain in their rural communities. We were able to leverage our existing telehealth care model to ensure continuity and check-ins for children with complex and chronic illness. I am so proud of the way that our rural communities pulled together to utilize the strengths that we had already established in our communities to further foster care and quality of care during the pandemic. Because we had been progressive in practicing telehealth years prior to the pandemic, we were able to partner with our colleagues in New York City and provide additional telehealth training and night coverage for our palliative care adult and pediatric colleagues at the height of the pandemic. It was interesting to be sitting on my back porch looking out at cornfields, taking care of families who were in the ICU in the Bronx, Brooklyn, and Manhattan. Really grateful for the ways that telehealth allows us to reach across miles and time spans to offer compassionate and competent care. We continue to foster ways to enhance training and competencies in communication using telehealth. While the modality isn't perfect, and the need is to ensure that the service modality fits the benefits for patients, the modality has a way of extending care and extending reach. Thank you.
So for our Medical University of South Carolina response during COVID, we really wanted to palliate our team members. So we started something called Code Lavender, which is used in other institutions. And as part of that, we did virtual debriefing for our teammates. We had about 10 sessions over a period of a couple months where folks could talk about their experiences with chaplains, with therapists, and with our bereavement coordinator, just to have peer support, which has been proven to be one of the most helpful things during potentially traumatizing experiences. And folks really responded well to that. We also were able to get donations from the community for self-care items, and we were able to distribute about 800 bags to teammates.
the entire COVID thing made us all pivot dramatically. So we made a point of giving everyone, frankly, iPhones so they could do FaceTime with families and see their loved one at the point we weren't allowing people in. We were going really spending a lot of time with the nurses doing debriefings unofficially on the units, but they became really important. And so all team members were, how do we support each other, but how do we support the staff caring for those patients? Within the ER and the ICU, the heavy lifting seemed even more so. So we were all there quite a bit of time. And getting the nurses involved in doing FaceTime also helped. We did a lot more legacy work so that the families would have memories that could go home with them if they couldn't be with them. And we did a lot of advocating for really everyone to support each other and ourselves as we went through this. Team building was, I think, dramatic, the way everyone stepped up to take care of each other. And it's clearly been a marathon. It's never been a sprint.
Hi, my name's Bree Burke. I'm a community health worker in Bristol, Tennessee.
Hi, my name's Nubia, and I was born in Mexico but currently live in Irvine, California. I am a community health worker in Huntington Beach.
Greetings, my name is Claude Clements, and I'm a resident of Philadelphia, born and raised in West Philadelphia. I'm also a community health worker. When we think about the COVID-19 that's hitting our nation, we're hitting the world right now, a lot of us, particularly myself, get phone calls every day, whereas I don't even want to pick the telephone up because I'm hearing about a loved one that's on a ventilator that has passed. I mean, currently right now, I have about 4 relatives of mine that are on ventilators throughout different parts of the country, and 3 that didn't make it.
The way that COVID has affected my community and my family is mainly through unemployment. My boyfriend lost his job at a gym and he hasn't been able to find any work.
So needless to say, COVID-19 completely threw us for a loop. But we knew we had to do the very best that we could to keep continuing to work with our patients and keep contact with them and meet their needs. We've provided gloves and masks to a local food pantry so they could open back up and help our patients and the community. We just kind of broke down what a community health worker is and tried to just go out there and help our community in any way that we can.
Calling a patient a couple of weeks ago, she said, I just have to let you know my son was shot last night. So there's so many other things going on top of COVID.
The pandemic has really interrupted the natural way of life, and quarantine, I find, has sparked some patients to get depressed. The media has also triggered a lot of anxiety and a lot of fear, and the patients that are higher risk are just afraid that they're going to get the virus and die. So I've been trying to support as many new patients that I take on with resources that we have, like food pantries for local churches, and even just setting goals with them to reduce their stress with the things that they enjoy doing. But the most effective tool that I feel has worked is just listening to them and being there for them and making them feel heard and understood. And also reminding them that, like, even though we're going through this pandemic, we live in a country that has abundant resources, and there's still yet a lot to be grateful for.
Again, I'm Karen Bullock, and I would like to thank our video speakers. And at this point, I would also like to introduce our additional speakers for this session. Beginning with, sorry, I'm having a little technical difficulty here. Can't get my list to come up. I apologize. Not sure when I missed. I'm having some technical difficulties.
I can introduce myself.
Okay, I'm sorry. I'll just read from what's right. So we have Carla Davis, I apologize, Chief Operating Officer from the Heart of Hospice. We also have Dr. Claire Nkuda, who is an assistant professor at Icahn School of Medicine in Mount Sinai. We have Dr. Christopher Hazley, who's clinical chaplain and bereavement support specialist. in addition to Dr. Susan Cohen, Medical Director for Palliative Care Program and Co-Chair of Palliative Care Council, Associate Clinical Professor of Medicine at NYU School of Medicine, New York Health and Hospitals at Bellevue. Turn it over to you.
All right, so I should just get started.
Yes.
Well, thanks everybody. I'm honored to be a part of this discussion and to share our story. So I was the CEO of Heart of Hospice, and Heart of Hospice is now a part of the LHC group, but we were not during the beginning of COVID, and that's the part of the story that I want to tell. Heart of Hospice had 16 locations in 5 states, Louisiana, Mississippi, Arkansas, Oklahoma, and South Carolina. So obviously some of the places that were hit early and hard, particularly New Orleans and the greater New Orleans area. And our hospice pre-COVID distinguishes itself by our mission, which is to serve every dying patient, regardless of the complexity of that care, the cost of that care. So we strive to overcome every barrier to a dying patient who wants our help getting access to it, whether that's treatments or caregivers or advanced directive choices. That's who we are. We try to knock down barriers to people getting the care that they need and deserve. And so when COVID came, it made complete sense to us that we would, of course, serve as many COVID patients as we needed to help our communities, and in particular to help the hospital systems, the health systems that you all have really dedicated yourselves to help them get the patients that were facing end of life and facing COVID home or to a different environment so that you could force and use your scarce resources to help patients who had a chance to live. And so we leaned into COVID, and we really felt like, if not hospice, who? And if not us, who would do it, and when would they do it? So over the course of the first year of COVID, we served over 1,000 COVID positive patients on our hospice program. That amounted to about 6% of the deaths in Louisiana. We are the largest hospice in Louisiana. And I honestly don't think that there's any acute care hospital that serves 6% of the deaths. So I'm very proud of the work that we were able to do to get people home or to a home-like environment and to be able to serve them so that they could be with their families and they could be in a place that they found comfort. Of course, not everyone that we served was able to get home. And I think the primary reason that I was invited to this panel was to talk about something that we did that I think was quite miraculous. And I'm going to share some lessons that I've learned through the whole process, the leadership lessons, through this COVID pandemic. But New Orleans was being hit particularly hard. Patients were in hallways, patients were in parking lots. I'm sure you saw that they opened the convention center and had 2,000 patients in the convention center. We had patients in 3 parks. Of course, we didn't know COVID was in America during Mardi Gras, and that was the reason that it really surprised us in the middle of March and towards the end of March. And so my medical director, our chief medical officer, Dr. Sonali Wilborn, had this crazy idea. She's like, there's got to be something more we can do to help out New Orleans. And she's like, we should open an inpatient unit and to take care of COVID patients. And, normally opening an inpatient unit, you have sort of a 2 to 3 year strategic plan. You don't just open an inpatient unit in the middle of COVID. But she was right. There was more that we needed to be able to do, to be able to help our communities and to be able to help these patients get reunited with their families and not have to die without contact with their families. And so we got together and said, what has to happen to open an inpatient unit? Well, you need regulatory approval, right? You need a space, you need staff, you need beds and drugs and supplies. And for goodness sakes, you definitely need PPE. Especially if we were going to be dedicating our unit to take care of only COVID positive patients. And so while it was a completely insane idea, we set up those lines and those lanes, and each of us started running aggressively down them as fast as we could, and not with any specific role definition. So Dr. Wilborn negotiated the lease, right? And anyway, we contacted the state of Louisiana, who at that time was in the middle of crisis and wanted solutions, wanted innovation, and was very supportive of our idea. And they said, come to us with a proposal. We're like, it's just an idea right now. But surely within 24 hours, we had a proposal to them. They approved the idea by the end of the day. And within 8 days of that approval, we were taking our first patients in our unit. And so I learned so many different lessons from that experience, as well as just our overall COVID experience. And one of them is that, what does it take to lead during crisis? I love Dr. Feinberg's comment about leadership emerges from action, because that's exactly what we did. We leaned in to figure out how to take care of these people, and barrier after barrier after barrier that you normally would think there's just absolutely no way you can open a hospice inpatient unit, a hospital, in 8 days. It just came down because I think what we were trying to do was right. It's what the community needed. And I think sometimes we artificially put these barriers around us, and more is actually possible. So, some of the lessons that I learned from a leadership perspective during this period of time is that, leadership during a crisis requires the same skills as leadership outside of a crisis, but it's more intense, and it has to be more intentional, and it has to be more focused, and every move counts. And so, what's important when you're leading? Well, first of all, to take care of your people. And so, the most important thing to me was that my team was going to be able to be safe, and that we were going to be able to figure out how to do that. It was important in any kind of leadership to connect people to the vision and mission, and what is it that we're doing or asking you to do, and how does that fulfill our mission? Whether it's going into someone's home that you don't know has COVID, going to someone's home that you do know has COVID, or volunteering to leave your home in another state and raise your hand and fly down to New Orleans to help us take care of that city. And we staffed the unit, because we were only approved for 90 days. We staffed the unit entirely with volunteers for 90 days. We now are permanently approved to have an inpatient unit in New Orleans, but to find volunteers. And you guys remember that time where people were scared to death, and their husbands didn't want them to go, but they said, I want to go, put me in, coach. This is what my mission in life is. So I think helping connect people to the vision and mission. The other thing is that in leadership, I think leadership with transparency, leadership with truth, leadership with vulnerability. I mean, there were times when I was scared. I got COVID myself from my 84-year-old mother, and I shared my lessons learned from that. So I think it was really important to be truthful and be transparent. And as I think several of you have said, over communicate. And so we set up regular formats of communication with weekly town halls, weekly emails, where they could see me on the screen and I could communicate, directly to them. The other thing that I learned is that when there is chaos going on around you, whether it's a hurricane, which we also had last year, Hurricane Laura, which devastated our operations on top of COVID, or it's a pandemic, is that to the extent that you can keep routine or establish routine and structure that is familiar, there's comfort in that when things are swirling around you. And then I guess the last thing that I will conclude with in terms of leadership lessons from COVID is that the improbable doesn't mean impossible. And anything is possible if you have a team that's united to that vision. So thank you very much for letting me share our story.
Thank you. We'll continue with our next speaker.
Hi, everyone. It's such a pleasure to be here talking about our Patch 24 service, which is the program that Dr. Chris Woodrell and I co-founded in New York City in spring 2020. Chris can't be here today, so I'll be presenting on behalf of both of us. Next slide. So Patch 24 has been presented in a prior roundtable meeting, and we've also published about it, but it was a model of rapid telephonic and in-person emergency department palliative care outreach to meet the needs of our health system during the spring 2020 COVID surge. So how did this work? We were really built around the design principle of never wanting any calls to go to voicemail from our overwhelmed clinicians and never wanting people to wait more than ideally 30 seconds to reach a trained palliative care clinician. So we had medical students who during the day sort of ran this complicated operating system where a call would come in from one of our hospitals. They would first reach out by a group text to a primary fellow physician and attending physician to see if they could take the call. If they couldn't, they would reach out to a backup pool that was comprised of physicians, nurse practitioners, sometimes volunteers from across the country. And if no one there was available, they would reach out to Chris or I. And then overnight from 8 p.m. to 8 a.m., there was always a primary fellow or attending staffing the phone line. Next slide. So you can see here in the figure the enormous volume of cases in the orange line that our health system saw in late March and April of 2020. As fast as that volume rose, it then fell to be almost back to where that baseline was by the end of May. You can see in the blue bars, our Patch 24 service really was able to mimic that volume change in the health system. In the light blue bars, you see the volume of consults seen by our telephonic service. In the dark blue, the number of consults seen by our in-person ED outreach, which I'll talk a bit more about. Overall, we saw just under 1,000 patients over that month. Next slide. So what lessons did we learn from this? And I think we've been doing a lot of processing both internally and then are also very grateful for the many conversations we've had with folks across the country who have been exploring different opportunities they have to create similar infrastructures to respond to the pandemic. Next slide. So first, we really found that telephonic consultation can be used to extend in-person services, but it does need to be properly integrated. We found that it was very important to have folks on the ground who are helping to identify patients who were right for our call line, helping to talk to clinicians on the ground in the emergency rooms and in the ICUs to identify the right patients. And finally, we found that from our call line perspective, while we could certainly speak to families in a one-time context, often these conversations did need to be longitudinal. So we needed to be able to hand the communication back to our primary consult services if needed. Next slide. And that really points to the importance of in-person presence and local champions. We've spoken to other institutions who have started similar call lines and just not gotten calls. And I think the reason why this worked is because we always had an on-the-ground approach. So early on in our operations, we had a day where the call line went really quiet, and yet we knew the hospitals were overwhelmed. Our clinical chief, in talking to the emergency room, soon realized they just didn't have a time to pick up the phone. So we started sending in one of our physicians as well as a fellow every day into the emergency rooms from 11 a.m. to 7 p.m. We also have several hospitals in our system that were less familiar with palliative care. So we also sent palliative care physicians into their hospitals to sort of build that bridge. These clinicians both helped coach when it was appropriate to use the call line and just really helped build familiarity with palliative care in general in our program specifically. Next slide.
So it may be obvious in listening to this, but our staffing model was not sustainable even for us. We really relied on predominantly physicians, and I'll talk about why I keep saying physicians more later in the presentation. Part of that was because some folks like me are people who normally do research and were redeployed to the clinical setting. Part of that was because we had a large number of physicians who typically work in outpatient practice or inpatient services where their operations were held up, and so they could be redeployed. However, this was really not sustainable for us in the long term. In addition, in talking to people who have experienced surges in other parts of the country, we relied on a large volunteer base, as was mentioned, other places did too, which was possible for us because New York State had COVID state of emergency laws, and our hospital had protocols that allowed us to rapidly onboard folks from across the country. In other states, that just wasn't possible. However, I do think that other models are feasible. We really overstaffed our program to, again, around this principle of never letting a call go to voicemail during this fairly extreme surge. And yet I think a much more simple model with 1 or 2 physician or nurse practitioner, or I'll talk later about the role of social workers or chaplains in this, can really see substantial volume on a call line. Next slide. And along those lines, with regards to crisis staffing, we really learned to be creative and to use who we had. So one example of that is 2 of our hospitals had a large number of residents, one from ophthalmology, another from psychiatry and interventional radiology. These residents were really looking, they needed to be redeployed. They were looking for a role. We were able to work with our social workers to create a training module where they all learned about New York State surrogate decision-making laws, which are a bit complex, and also learn how to have conversations with patients about healthcare proxies. We then deployed these residents in our emergency departments. They saw every single patient. If the patient had capacity, they asked them who they wanted to be their healthcare proxy and completed appropriate paperwork and placed that in the chart. If they didn't have capacity, they would start the process of searching for who was in their life, not just identifying the appropriate person, but also trying to document their contact information. This did incredible good both in the emergency room and later on in the hospital stay. Next slide. We also found one surprising lesson was that telemedicine provided an excellent platform for teaching. Often on our call line, so our communication team had come up with communication scripts of how you talk about COVID decision-making in low acute and sort of medium acute situations and the kind of high acute situations that we were often working with on our call line. We were able to arrange it so if there was capacity, the fellow would have the script pulled up in front of them. They would be on the phone with the family. The attending would be there listening and would be able to actually provide coaching in real time via text or a chat on the computer. This was a really nice model for feedback. And we also found that, speaking to the last point of using who you had, these were March and April fellows in geriatrics and palliative care, and we were really able to give them much more autonomy than we typically would have given fellows at the time. And they reported to us that autonomy and chance to sort of maybe step a little farther outside of their comfort zone than we would have sort of normally done was incredibly beneficial for their learning, and they really appreciated that opportunity. And we couldn't have done this without our fellows. Next slide. Similar to as has been discussed, this idea about over communication was really important for us in adapting. We had daily 8 a.m. and 8 p.m. huddles, often for just 15 minutes, but to talk about what happened in the day, to talk about any glitches, to brainstorm solutions to the glitches, and to disseminate any new solutions or adaptations we had. We were constantly doing this every day, and these debriefs were really important for us to really roll out the program. We also found that they were incredibly important for us to connect, especially for our physicians who we were sending to sort of hospitals they weren't normally in. It was really helpful to have that community at 8 a.m. and 8 p.m. every day. Of course, as the pandemic moved on, I think we were all initially quite relieved to sort of be able to talk about COVID less and have less meeting time. But I think a lot of us have really missed that high touch of the early days of the pandemic. Next slide. And I have spoken about this before, but our program, we've really thought about in the future how we would better involve our IDT. We did to some degree through training and then through follow-up after calls. And I think the reason why our program was so physician-centered was, as I said, in part, it was who we had. Our chaplains and our social workers were really entirely consumed with their expanded roles on the sort of typical consult teams, given our consult teams were also embedded in the ICUs now. So we really didn't have a lot of time from our social workers or chaplains. And yet I think a model where we were appropriately screening patients and families to see who really needed more help from the full IDT. And even if it wasn't everyone joining in the same call, at least some sequential communication with the full IDT, I think would have been really useful and something we just didn't get to in terms of our planning. Next slide. Finally, one thing we worried a lot about did not come to fruition. In crisis mode, our work shifted to really taking over primary palliative care, not coaching as is our normal role. We also really worried of, gosh, in holding family meetings when the ED asks us to at 2 a.m., is this going to be hard to revert, when they're calling our fellows all night? But we actually found that wasn't a problem at all. Everyone sort of understood that we were all acting outside of our normal workflow, and it was quite simple to move back to our normal care delivery after the surge. Next slide. So that is all I have. Thank you very much. I look forward to the discussion later.
Let me begin by saying thank you so much for this opportunity to be here. And I'm going to be sharing from the perspective of a clinical chaplain as well as the perspective of a bereavement support specialist. And so I worked at the time as a per diem hospital chaplain for a local hospital. And of course, I currently work as a hospice specialist. So from that perspective, to speak on the early response to the pandemic, one of the things that I witnessed was the uncertainty. And many of the panelists have already shared this in previous sessions, the uncertainty of how to support patients and families, as well as staff, because of what we normally are used to as relates to end-of-life care. Those things had to change. So meaning we had to come up with a way as an interdisciplinary team to now support patients and families based on the pandemic restrictions. And I know it was shared in the past, but for example, you had long-term care facilities that were closed to staff, hospice staff, for the fear of, bringing the virus in. And so, that didn't allow family or patients to get the support of the hospice staff, of course, the facility staff, but they needed the hospice staff, the specialists to come in to provide that support to their for their end-of-life needs, which also included the restriction for the family. So now the family wasn't able to come in, of course, also not just in the long-term care facilities, but also in the local hospital. So you had that frustration. It was mentioned earlier how, families were glued to their Chromebooks, their smartphones, their tablets to kind of get some information as to how their loved one is doing. I know I had a personal experience. My aunt, who lived in a long-term care facility, was very sick and ended up passing away due to the virus. And normally, we're used to going to the bedside as a family to gather and grieve, but we were not allowed to do that, which didn't allow us to have that sense of closure. And so, personally, I felt that the weight from what our families were dealing with. And so, again, providing that support was for that loss of that closure wasn't there, which led to what's now labeled as pandemic grief. And so I also can remember from a chaplain standpoint when one of the nurses in our IPU units struggled because we had a patient that passed away on a unit, and she had to bring the body to the morgue, the hospital morgue. And so when she gets to the morgue, she sees all these bodies. She had never seen this before. She was very traumatized by this. And I remember getting the call from my director to meet with her, and there was like 9 o'clock at night. So I remember going there, meeting with her, talking with her, trying to help her and support her and deal with her emotions at that particular time. In addition to that, I remember just the various roles that I had to take on as a clinical chaplain. And in the hospital where I worked, I would do Sunday services for the patients, and it used to be in person, so we had to change that to virtual. So we had to issue Chromebooks to our patients that were in their rooms. Of course, we created a virtual platform or a Zoom link, so we can still give them what they need as it relates to their spiritual care and support. And still, patients were still struggling with that because they wanted that one-on-one care, that one-on-one support for them. And so seeing all that was a struggle for our families, but the various roles that chaplains had to play, some of my colleagues had to play, were enormous, providing support to the staff. Debriefing things were put into place, trying to get a hold on what was going on, trying to kind of see where the staff were at that particular time. And so seeing all that was a challenge at that time. I also can remember the support that needed to be provided in the community, because I also work as a community clergy, and partnering with the local Department of Public Health to help churches and faith leaders provide support to their congregations, because they didn't know what to do because they wasn't allowed into the facilities at the time. And so I remember partnering or instituting partnerships with the local Department of Public Health to provide testing for the community, open dialogue that was much needed at that particular time. So what I believe we learned through this pandemic was how it's important for all of us to work together as a discipline based on our scope of practice, especially in times of crisis. Again, providing virtual support or wellness debriefing was huge. Just giving people an opportunity to kind of see where they are to help them through the process that they was experiencing at that time. And so knowing that working together is something that's essential. I think just being respectful of each other's position, as was shared a minute ago, that again, chaplains, we were kind of, we had a lot of things that we had to handle. And then also providing self-care. I think one of the messages that I would say to the staff was that, hey, listen, it's time for you to provide care for yourself. There's a saying, so who takes care of a Superman? I always say Superman and Superwoman typically takes care of themselves. And so I talked about the essentials of that and how important that was in order to provide care for those patients. So yeah, it was a myriad of things that I witnessed from a chaplain standpoint and from the bereavement specialist standpoint, the need to continue to be there for people even after the fact, because the stats or studies have shown recently that there will be a bereavement crisis that's going to come on the rise even more since last year. So continuing to partner together as disciplines is important, and then like I said, working together is huge. It's very vital during this time. So that's some of the things that I've learned during this pandemic. Thank you.
Hi, everyone. My name is Susan Cohen, and I want to thank everyone for allowing me to join and share my story and the story of Bellevue Hospital. Before we start the slides, I just I'm thinking a lot about the presentations already today, and I realized that today is really about stories, stories of patients and families and providers, stories of crisis, trauma, resilience, and really how humanity comes together. And I want to just mention some words and themes that I've heard across the morning that I think, or the afternoon, that I think also are highlighted in my presentation, which is, and these are all quotes from someone this morning. There was a sprint and now it's a marathon. The idea of change and adaptability, the idea of working through uncertainty, which palliative care is trained to do anyway. I love the quote from Dr. Wang this morning, anxious preparedness. I love that phrase. Relationships and nurturing ourselves and learning while doing. I think I can relate to all of these things. Next slide, please. I have no disclosures. And next slide. So when we talk about the Bellevue experience, I just like to put the context around it. It's the setting for the story. This is our country's oldest hospital, Bellevue Hospital, and it's part of an 11 hospital, 5 nursing home system. It is the largest safety net system. So safety net systems are under-resourced very often, and we care for diverse, often uninsured or underinsured patients. And that Bellevue has a very long history of dealing with pandemics and epidemics, whether it's yellow fever, cholera, TB, HIV, smallpox, and also emergencies like Hurricane Sandy when our hospital was evacuated, and Ebola. In addition to that, it's important to remember the context of our patients is that many of them have histories of trauma, poor access to care, cultural and linguistic barriers or challenges and inequities. And this, I'll tell a story or two of how this played out. Next slide, please. So it's important also to force ourselves to remember what it was like and what that fear and emotion that was right in the middle of our chest during spring of 2020. We didn't know about PPE availability. No one wanted to keep families away, but we were also really concerned we would run out of PPE. Tests took 4 or 5 days to result back, and were only for those who were hospitalized. I don't think people kind of remember this, but the mask mandates didn't come until May of 2020 when the surge here was really waning. And that New York City was really one of the first places to experience the surge to this extent. I spoke to my colleagues in Seattle, where the first cases were kind of surging, but it was nothing like it was here. In fact, some of our colleagues that worked at Bellevue moved to Seattle and then came back to help us during the surge. So they said it was nothing like it was here. There were no treatments, no vaccines, and we weren't even convinced about droplet versus airborne precautions, if you can remember that. Next slide, please. So this is what I walked past every day from the parking lot to the back of the hospital. And this is 3 of the 12 or so refrigerated trucks. I think it's important to show this as part of the context, because when we're talking about traumatized staff, this was our everyday experience. Next slide, please. So when I think about the planning and the preparedness and what we did, I like to use the analogy of the tsunami. So I don't know if people remember when the Indonesian tsunami hit, there were videos online about what happens before the tsunami, that people in the know recognize that the water recedes very, very far into the ocean before the tsunami comes and hits landfall. And that's how I felt during the preparing stages. I knew what was coming. I was reading the material out of Italy and China, and I was really panicky about what we could do. I spoke to colleagues in Seattle. I procured surge plans. We created guidelines here. We looked at the New York State guidelines. But in the end, I think the learning while doing really was what I kind of went with. It really didn't matter. I think the planning from the preparedness as a general idea made sense, but you had to be adaptable with your plans individually from each program. Next slide, please. And then we talked a lot about telehealth today, and I think I loved Claire's comments about it can't just be one or the other. And what we realized here in our setting was that very early on in the surge, there was very, very, very little information that was useful in the EMR. And we were getting 20 to 40 of the sickest transfers a day. Our hospital functioned to level load off of other hospitals in the system who were more hard hit in the outer boroughs. So we weren't getting a lot through the ER. And so the ER wasn't the place where we parked ourselves. They were coming to the ERs at Elmhurst, at Woodhull, at Lincoln Hospital in the other boroughs, and then they were transferring patients to us. What we decided to do when we were upscaling our ability to take care of patients from the palliative care perspective was we wanted to avoid a never event that did take place at one of the other hospitals, which is that people were making calls outside of the hospital, but they weren't getting real-time information. And we heard of a story where someone got an update and a death call within minutes of each other because the information that the caller was using was not accurate and up to date in real time. And we didn't want that to ever happen to our families. So what we did was we parked ourselves and embedded ourselves in the ICU. We saw patients with the ICU and we paired up so that we had good relational communication with the ICU teams. And then we made calls only once we saw them and communicated with the ICU. Overall, as a system, we did utilize telehealth, but we really felt like that in-person embedded practice made a huge difference for our patients. Next slide, please. What we did to rapidly increase was to incorporate in-person volunteers, including Dr. Salerno was one of our volunteers. And they worked closely with us, had some brief trainings using things from CAPC and Vital Talk and some other materials, and then having close mentorship by working really closely with a team that included one of our attendings, our fellows, and some of our other practitioners. We increased from 1 team to 3 teams. Our census increased by 4-fold. Fellows took on leadership roles and we embedded ourselves, as I said, and we increased to 7 days a week in-house coverage for about 5 or 6 weeks. And most of our volunteers were actually from child and adolescent psychiatry, but also community-based psychiatrists. Only 2 palliative care providers. Dr. Salerno is a geriatrician, 1 internist, and not everybody was full-time, but some were. And utilizing people on the days they could be here, we covered the programs. Next slide, please. This is just a picture of some of our permanent staff, some of our fellows, and some of our volunteers. Just one thing to point out is that one of the people in this picture was a student of one of the other people in this picture who was her dean when she was a medical student, and she was now a fellow. So the learner becomes the teacher, and she was teaching her former dean how to do palliative care. Next slide, please. So as I mentioned, we were level loading off of other hospitals in the system, and we were also an ECMO referral center, and our ECMO program literally got going during the surge. The palliative team roles included medical updates as well as supportive care. And as others mentioned, we were doing a lot of primary palliative care, and people did revert back to knowing that we weren't going to be doing all the primary palliative care. Many of our patients were young, and so they were previously healthy. So goals were for life-sustaining treatment. And we were really supporting teams through a lot of ethical issues as well. Next slide. So we were providing support for teams, but we were also trying to be mindful of our own team wellness. And I wanted to put another plug in for this issue of wellness and resilience that has come up a couple times this morning. Fortunately, our wellness work had already started the year prior. Just fortuitously, we had a team retreat to really work on our team and our team's wellness. And we had also worked with a team wellness coordinator who we enlisted during COVID to do every other week sessions. And we divided those sessions by our core palliative care team did 1 session. We had another session for fellows and other sessions for volunteers. Our hospital also has a program called Helping Healers Heal. We had respite rooms and other, wellness activities. But what was important to note, and I think is important to continue to remember, is that each team member had a different trajectory for their fear, their grief, their anger, and their gratitude. And then right as we were coming off the surge, of course, the horrible tragedy of George Floyd's murder. And this also had a huge impact on our team, on our patients, on our system, and was a repeat trauma for everybody involved, and impacted just our wellness again. Next slide, please.
That's the last slide I have for you, Susan.
Oh, there's a summary slide that should be there, but I guess it's not. So in summary, what I have on my summary slide is really just that the history and culture of Bellevue and health and hospital system really helped with our preparedness, having dealt with so many tragedies, emergencies in the past. The ability to adapt and shift, which has been emphasized earlier, was my main emphasis. I love Dr. Carroll's change mnemonic. The ability to see each setting as unique. So what worked at Bellevue wasn't going to work at our other sister hospitals. And I think really being mindful of the individual institutional culture is critical. And then our prior team wellness work was an important foundation for us to be able to get through what we got through. Thank you.
Thank you so much to all of our speakers. And before we move to our panel discussion, we wanted to really make sure that we had a critical focus on the issue of health equity. As Dr. Feinberg said earlier, disparities in healthcare were exacerbated and revealed during this pandemic. And pretty quickly, we realized we have a lot of work to do in this area. Beyond what we already knew we needed to do. It is my privilege to introduce Dr. Ebony Bowar. And Dr. Bowar is a distinguished professor at the Duke School of Medicine. You can see all about her bio, but I know we're short on time, so I'm going to turn it directly over to you now.
I believe you're muted.
Sorry about that. I was saying thank you. And I was saying in a session prior to this, some of the speakers had come together and one of my colleagues had said, the inequity story is the pandemic story. And I quickly wrote that down because I feel strongly that for many of us, this is the underlying story that the COVID-19 pandemic has really brought forth. And if you could move to the next slide, please. I think, one thing that was very clear was in all of the stories that we've heard and just sort of what's been told, the experience has not been equal across our country. And, individuals from historically underserved communities have borne extremely much more of the brunt of the COVID-19 pandemic. And that became so clear, illustrated, unfortunately, not surprisingly so, but very clear in mid-2020. And on the left-hand side, what we saw were that COVID-19 associated hospitalizations were much greater among individuals from Indigenous backgrounds, from Black individuals, Hispanic and Latinx communities when compared to other communities. And we saw that both among by hospitalizations as well as death rates on the right. So 4 to 6-fold greater hospitalization rates and death rates due to COVID-19 by mid-2020. You go to the next slide, please. And I think one of the things was that we were also experiencing were just the perfect storm of social and environmental catastrophes happening related to the pandemic as a cause of the pandemic, but just exacerbation of underlying weaknesses. And so while we were experiencing the tremendous health effects, we were also experiencing job loss. Many groups were experiencing severe economic instability, mental health effects from the pandemic, and structural barriers to healthcare. Next slide, please. And what I have here is just looking at what was happening, two aspects on this slide, looking at what was happening with regard to job loss and health insurance changes during the pandemic. So as jobs were, first we know that people from from historically disadvantaged backgrounds, those communities, people living in those communities were much more likely to work in vulnerable jobs or positions where they were on the front lines of the pandemic
I mean, often not with the protections, with any workplace protections to protect them against exposure. And then also sort of being the most readily sort of people that could be laid off in the context of the pandemic. And so what we saw by mid 2020 were that job loss was highly prevalent among everyone, but as you could see on the left-hand side, that blue bar, our job percent of unemployed among Latinx and Black communities compared to the white communities. And you could see that there was just a large racial inequity with regard to that. And on the right-hand side, it's a little hard to see, but what I was trying to pull up here, where this was a study that was actually just recently published, but looking at rates of health insurance coverage and how health insurance coverage changed during the pandemic. And because of job loss, and employer-based health insurance actually went down among these very same groups. So those individuals from Black communities, Latinx communities, much more likely to lose employer-based health insurance during that aspect of the pandemic. So just when people need health insurance, they were losing it. And that was related also to the economic problems brought on by COVID-19. Next slide. Also, economic instability was very prevalent, and that of course would affect people's desire or willingness or ability to even get healthcare. So this was a study done by the Commonwealth Fund that asked individuals in mid 2020 whether they were able to pay for basic necessities like food, heat, or rent, whether they'd used up most or all of their savings, whether they'd borrowed money or taken out a loan. And the bars represent white individuals, Black individuals, and Latino individuals. And what you can see is that Black and Latino individuals are much more likely to say they couldn't pay for basic necessities for life, had used up most or all of their savings, and had borrowed money to take out a loan. And these are social determinants, social factors that definitely affect health. And so we were seeing that playing out in real time. Next slide. This is another slide just looking at the mental health and coping effects. I think the consistent theme that I've just been hearing in all the presentations were just the difficulty in managing the pandemic. And those difficulties definitely played out along racial inequity lines, as well as other types of inequities, income as well, and gender. So this is another part of this same Commonwealth survey asking people, did they experience stress, anxiety, or great sadness that they found difficult to cope with on their own since the COVID-19 pandemic began, and this was mid-2020. And as you can see, rates of a positive response to saying yes, they had experienced difficulty, stress, anxiety, or great sadness was much greater among Black individuals, Latino individuals, women, and those with below average income. Next slide. At the same time, as we've heard this again coming out in the other talks, is people were delaying care, in part because of fear, in part because of maybe difficulty and other barriers to getting to care, in part because of some of these other social barriers or social difficulties. And so this was a question coming from a questionnaire that was out of NPR, Robert Wood Johnson Foundation, and Harvard T.H. Chan School of Public Health. And in this survey, they asked people, have you been unable or, this was mid-2020 again, unable or to get or delayed getting medical care for a serious medical problem? And in the blue bars are on the left-hand side of the people that said yes. So 20% of respondents said yes, they'd been unable to get care or had delayed getting care for a serious medical problem. And then of those who said they had delayed, those this on the right-hand side of the proportion of people who said delays resulted in a negative health consequence. And so of the 20% who said they had delayed care, 57% said the delays resulted in a negative health consequence. And then looking at who was delaying care, Black and Hispanic individuals were 1.5 to 2-fold more likely to have delayed or avoided urgent or emergency care when compared to white individuals. So not only was this a problem for anybody, but it was much more exacerbated among historically disadvantaged communities. If you move to the next slide, please. And we've heard, talking about and remembering the widespread health service disruptions that affected seriously ill communities. and there was a reassignment of staff and postponing of screening, as others have mentioned. That did lead people to have to use alternative methods of connection, the phone and telehealth. And I agree that that was sort of a bright spot, and to some extent a test of a new way of folks working together. If you go to the next slide, there was an interesting study that was looking at people who reported in March 2020 that they'd used the internet or email to connect with doctors or other medical professionals as a result of the coronavirus outbreak. And on the right-hand side was a figure from that study. And they were looking overall by race at who'd responded that they had used internet or email. And what I think is interesting is to look at among Black individuals, Latino individuals, and others, they actually may have had comparable, if not higher rates of using that during the outbreak. Next slide. Another aspect I think is very important that I don't think has really gotten as much, at least I haven't heard it talked about quite as much, is the importance of timely access to care as a key contributor to the inequities that we have been seeing. There were at least 2 studies, but there were others that showed that although people from disadvantaged backgrounds were more likely to show up to the hospital with severe COVID, that once they got into the hospital, the death rates were very similar. So on the left-hand side, there was a study that came out in mid-2020. It was looking at patients, or it may come out a little bit later than that, but it was looking at patients, 3,000 patients who were hospitalized in Louisiana from March to April 2020. And what they found for COVID-19, what they found were that nearly 77% of patients who were hospitalized were Black individuals, and the Black individuals, Black patients were more likely to present more sick with more comorbidity and more advanced disease when compared to non-Black individuals. But once people were in the hospital, Black race was not associated with in-hospital death. And so that was an interesting finding. Another study of over 11,000 patients across 12 states found a very similar finding. While 37% of the hospitalized patients over all those states were Black individuals, those Black patients presented sicker and they were more likely to be socially disadvantaged. Once they got into the hospital, the in-hospital death rates were similar. And what I take from this are that access to care makes a difference. When people have delayed care, they show up sicker, and there's a number of reasons why they may have delayed care. It could be workplace conditions, it could be structural barriers to care, like difficulty getting transportation, other economic or other types of barriers. They show up sicker, but once they have access to care, it appears that inequities could be mitigated. So the importance of access to care as a key contributor to the inequities and the outcomes. Next slide, please. This is, I think, almost my final slide, which is to say the face of the COVID-19 pandemic is really changing. This is a depiction from, I think it's second to last slide, the depiction from the Centers for Disease Control, looking at racial inequities in COVID-19 weekly deaths per 100,000 population. And then on the bottom are the months going from April 2020 all the way to October 2021. And in the top right, that top red dotted line are Black individuals, and then that darker teal line are Hispanic individuals. And what you can see is that in the initial surges of the pandemic, Black individuals and Hispanic / Latinx individuals were more likely to be hit, as I'd shown you before, with morbidity and mortality of COVID-19. But as the pandemic has shifted, as time has gone by, we see that other groups have also experienced the inequities, such that in June of 2021, we're seeing American Indians or Indigenous individuals and Alaskan Natives experiencing much greater inequities than other groups. So we can't always think that what we saw in the beginning is the pattern that's happening over time, and that these patterns are changing and continue to change. It's something we need to really monitor and keep an eye out and focus on the groups experiencing inequities at the time. Next slide, please. So my take in thinking about the inequity story of the pandemic story, which to me is the story, is that we do need to really monitor these. I think the pandemic clearly brings out the weaknesses in our in our healthcare safety net that, and also our societal factors that really can lead to health inequities. It just stressed the system and brought out all of the weaknesses that we'd already been seeing just more rapidly and more severely. And I think one of the lessons of the pandemic are that we can not only just focus on addressing the medical needs, which are substantial during a pandemic such as this, but also the non-medical determinants, housing, employment, and the rest of our social safety net to deal with the inequities. And I think at the end of the day, what's become clear is that the answers cannot just come from within the healthcare and public health sectors. They really need to come from across multiple sectors of society in order to address the inequities. Again, thinking about employment, health insurance, economic instability, and other structural barriers. So thank you.
Great. Thank you again, Dr. Bowar, and thanks to all of the speakers for this session. At this time, we'll open it out for a discussion, and if the audience would please submit your questions in the Q&A box, Lori and I will facilitate the discussion.
Do you want me to get us started, Karen, with our wonderful panel?
Sure.
With the question while we're waiting for more questions to come in the Q&A?
Sure.
First of all, just thank you all. I was struck by the fact that you all leaned in. I think that Carla mentioned that as our first speaker in this session, but it seems you all have leaned in during COVID. And it made me wonder two things. One was about the partnerships that were created to lean in and provide your intervention or your support. So what's happening with those partnerships long-term as a result of that? And then what of your innovation is going to continue? I don't know who wants to go first with that, but would love to hear from all of you.
I'll start. I think that during COVID, the height of COVID, the health systems appreciated the innovation and the responsiveness in a way that got us more attention. And we were, for the first time, being perceived as a true partner. And the C-level suites wanted solutions for an innovation, and we're willing to meet with you to discuss that in a way that I had not seen prior to. So I would say I had more and I'm not talking about just the hospital that we opened our inpatient unit in. I'm talking across, all 16 of our markets. I had more C-level meetings in that 1 year than I had had in the 5 years prior. Like that, and some of them are virtual, and it's the South, so some of them were in person. So I think that they were open to the value proposition of hospice and palliative care, as many of the speakers have said today, in a way that they hadn't allowed themselves to be, because the crisis was upon us. So, and in terms of the innovation of the partnerships, I think that people aren't forgetting what you did when they needed you to do it. And we actually grew through the experience. And definitely, the hospital where our IPU is, we are going to continue that. I met with executive leadership 2 weeks ago, and they're thrilled about the partnership. But it was, like, I will say, and I would love for someone to do research on this, but I think how each market responded to COVID and accepted hospice as a part of the solution was highly variant, even in the Deep South. And I wonder if somebody would do how many beds were available to how much hospice got utilized comparison, because I saw it vary even in the same market based off of how the cases were flowing. So people stayed in the hospital and died with COVID when they had beds. They were discharged to hospice and home when they didn't. So it would be interesting to look at.
Lori, I'd like to comment on the part of your question about relationships, if I could. Just like I think our foundational work on wellness really helped give us a a platform to succeed. I think the relationships we'd built in our ICUs was critical to our being able to upscale and create this program where we sort of just like stuck ourselves there. They weren't calling in the beginning because they were too busy, and we just showed up and they embraced us and couldn't, we leaned in and they couldn't wait to have our help. But if we hadn't built those relationships before, that wouldn't have been the case. And so I think it's like low-hanging fruit. When you have the relationships already established, it's an easy way in, and you can work together to figure out what the best solution is.
Yeah, I think similar to that, in terms of relationships with the emergency department, with our innovations in Patch, we certainly already had some relationship in that actually all of the emergency medicine residents rotate with our palliative care teams. And that was really interest from a few champions in the ED. However, I will say that within some of our hospitals in other parts of the city, their emergency departments prior to the pandemic were really not so bought into palliative care. One of my friends is duly trained and did a survey of them asking physicians, he happened to do this in the end of 2019, asking them if they thought, this is ED physicians, if they thought palliative care was part of their job. And the majority said no. And then he resurveyed them after the pandemic and the majority said yes. And now they want trainings from us. They want rotations. They want a lot more. And so I think some of that was relationship, but some of it was seeing what we do and seeing this new need that they had that I don't think they'd really had in the same way before.
Great, thanks everyone. I have a question I'd like to pose to Dr. Christopher Hazley. Thinking about Dr. Carroll's presentation earlier and then hearing your presentation as well, I'm really struck by this notion of hope and healing. And I'm wondering, based on your experience and the work that you described during your presentation, whether this hope and healing concept resonates and if it's perhaps looks similarly or differently in the setting that you're working in.
Well, yeah, I would say that definitely hope and healing was huge or is huge still because of, there's still some uncertainty, right? Like what's going to happen? What are we going to do next? People still having the fear of if they're going to be infected, right? The other question is, should they get the booster? Should they get the vaccine? And that happens. These questions are coming from the spiritual perspective, right? And so I guess what I've learned is just continue to offer hope to the individuals, to the patients, to the families, to remind them, that you have to do what's best for you, but these are the possible ramifications. So I would always collaborate with, my other clinicians, right? So physicians and nurses and all those to bring educational opportunities to families. I know, again, as a pastor and a chaplain, I would provide talks at my local church virtually, so the community could understand the importance of doing what needs to be done, so we can possibly move on past this. And so, keeping that hope, it was huge. Allowing the healing to take place and just coming alongside people is huge. So I think that's keeping the hope there is important.
Thank you very much. And thank you, Dr. Carroll, for your presentation and emphasizing and really, as I said, resonated with me. And so if I may, Dr. Bowar, your presentation and the way in which you framed the need to address the determinants of inequities, I think is really critically important. We talk a lot about the social determinants of health and not as much about the determinants of inequities. And so I have a question for you about what do you think are some of the greatest challenges to addressing determinants of inequities as we continue to focus on these social determinants of health?
It's a great question. I think the when we talk about the determinants of inequities, there are often things that are not within the healthcare environment. So we talk about, so many of the interventions that we've been talking about today assumed the person was actually able to get into the healthcare system, or had, that the barriers to actually carrying out the care that are provided or that are recommended are that there are no barriers, or that there are minimum barriers. And I think what's required is that we begin to think about sort of the arc of healthcare as everything it requires for an individual to show up and be able to get what they need out of the healthcare system. And if we can't get people there, then they just don't get what we want them to get. So that means going back to the structural barriers, the economic and the economic barriers, all these other barriers, and kind of saying, all right, if I offer a service in the healthcare system, what is it going to require for our patients to get to that? Can they get there? Is it open at the right time? Are there certain barriers that will keep them from being able to show up? If we provide recommendations or we have a treatment, can they afford it? Can they take it? What are going to be those barriers? So I think it requires a lens that backs up beyond, before and after the healthcare, the episode of exchanging the healthcare advice and providing the healthcare, to what it takes to get and receive healthcare. Again, and I also think a challenge is that it requires partnerships beyond, the public health and the health system infrastructures that we have, really kind of going towards those other in other institutions that we rely on, particularly community-based organizations, government organizations, to really all work in tandem to address these needs.
Thank you very much. I often hear colleagues talk about building it. If we build it, they will come. But sometimes coming isn't just the transportation. It can be transportation, but again, sorry to keep going back to you, Dr. Carroll, but it could be something like cultural. If we don't have a system of care that, as Dr. Hazley just said, that really supports those who are hopeful. And what does that look like? And the spiritual care. We often talk about the spiritual care of the patient, but I ask clinicians, what does that mean? And they'll often say referral to the chaplain. But there's more to spiritual care than the referral to the chaplain. So what comes in between that? And so there may be some structural barriers operating around spiritual needs, or, this notion of faith. And what do we do with faith in the healthcare setting? So I appreciate being able to focus on inequities around these, as you said, perhaps some people view them as non-tangible, when actually they might be more tangible than we know to think. So thank you.
Karen, we have a question in the chat that I think we're in the Q&A that we should give to our group here. And as this pandemic goes on and on and on, many nurses are leaving or retiring early, certainly other sectors of healthcare as well, not just nursing. The workplace is stressed, staff are taking out their frustrations, sometimes even on each other. What can we do now that we've had some time to reflect? And I think some of you have alluded to, or at least we've heard from speakers throughout the sessions today about self-care, but how do we also need to think about the long-term impact on healthcare professions and what needs to happen?
I'm actually very interested to see how this plays out. I think wellness, resilience, self-care, whatever you want to call it, there's all kinds of names. Some of those things fall on the individual or the team, and some fall on the system. And the system got ignored for a long time. It was all kind of like, you need to take care of yourself. It was another responsibility we were given as providers. And I think we're realizing more and more that there needs to be resilience within the system and wellness built into the system. I don't think the system knows how to do that yet. I think it thinks that having a room and a massage once a month is going to do it, and that's not what's going to do it. So I'm actually I don't have the answer for your question, but I hope that this will be researched very, very critically over the coming months, because we are facing another crisis. If all of healthcare providers, the crisis in my day was it cost so much to go to medical school, I'm still paying my loans. And and people didn't want to go into it for that. And we had to restructure how we were doing that. And we've come up with some programs, not enough, but now it's really about how to get people to come into the system, stay in the system, and be able to function well in the system without being angry and irritable and burned out and disengaged. So I think it's something that the whole system faces, just like we face a crisis in how we're going to pay for things and how people are going to get access to things. We have to start paying a little bit more attention to providers.
Anyone else want to take a shot at that one?
There are many who I think have spent so much more time than I have been thinking about this, Susan being one of them. But I think one thing that we noticed strikingly was the extraordinary camaraderie and sense of spirit at the start of the pandemic. Now, I think part of that was the energy of the time, right? Like we thought it would be over soon, you know, it was this, you know, we could all band together and do something. But I also wonder how much of that was, as people mentioned, we had a lot more freedom to create. We had a lot less paperwork and regulatory burden. We were all working at the top of our license, and we were all driven by intense meaning in what we were doing. And so I think as much as we need, you know, the traditional wellness focus on well-being and meditation and all these other skills, we also need our work to be going well in terms of all of us, you know, doing what we were meant to do without the sort of burdens that we all struggle with of the EMR and the paperwork and all of that.
Well said, well said. Meaning-based. Viktor Frankl kind of led us that way a long time ago, and maybe we need to go back to those beginnings. If we find meaning in our work, we're usually more resilient.
And Christopher, I feel like you're in one of those positions that a lot of people rely on you to help them as a colleague to provide that emotional and spiritual support to get through the day, to get through the week. So where do you go, and where do chaplains go, and social workers for that matter, Karen, to get that support when they're providing it to others?
So I would say that as a chaplain, I always go to someone, another colleague, right, to debrief, non-judgmental listening. And then in addition to that, I utilize the tools that I tell everyone else to do, or encourage everyone else to do. Not tell them, but I encourage everyone else to do. So, you know, finding your favorite hobby, doing it as much as you can, being intentional about it. I found myself during the pandemic because, you know, as all of us here and those that are listening, watching, we didn't have the privilege of staying home, right? We still had to go every day. And I, you know, my wife and I, we had our baby in 2020, right? So my wife was pregnant during the whole time, but I was out of the house. And so, you know, trying to support her and our other children and do this work, I had to do my part of being well, which was, you know, being an intention of doing the things that bring me restorative care. So again, going to colleagues, mentors was or is one of the things that I do and encourage other chaplains and even social workers to do as well.
Lori, I was going to go back to Claire's comment because I do think that the fear and the focus of the crisis initially did not only connect us to our why, but we were forced to innovate, I think. And we did have regulatory freedom somewhat, and you were just trying to survive the day. And I do think kind of looking forward, you know, even thinking through different models of care delivery, how to do hospice differently, what could be centralized, what has to be done, and what has to be done in the definition of the visit, what could be done better in a virtual visit or a telephone call, how can we coordinate care essentially? Like it allowed your mind to go places you don't let it go normally. And I don't want to lose that as we sort of create what the future looks like for serious illness.
Karen, are you there?
I am here. I was not for a moment, but I am now. Sorry. I was kicked out, but I'm back.
Do you want to take the next question in the chat? And one maybe follow up for Carla's creative spirit there is, sounds like we need to apply that creative spirit to access to care based on Ebony's statements and comments. So, but Karen, do you want?
I'm sorry, Lori, I think I'm still having some, I didn't hear the last part of what you said, so maybe we should continue on with the.
Do you want to take the question in the Q&A?
Because I was kicked out and back in, I can't see the question, so.
Okay, so this is a great one too. As a result of COVID and the emergence of long COVID, what have you learned regarding the new expectations of employers, what they want more of, what they want less of regarding new processes, solutions, especially since they have retirees to manage and pay for during and after COVID? Any brave soul want to start with that one?
I don't really know what the expectations of employers are, but I guess I can think just about the leaders in my own facility. You know, I'm not really employed by them, but they are our bosses and our leaders. I think that they appreciated that camaraderie and spirit of teamwork that kind of was highlighted during the early parts of the pandemic that Clara mentioned. And they appreciate the innovation that Carla mentioned. And whether or not they can sustain that through more normal times, I guess, is what we'll need to see. I think, you know, leaders at every level learn things during this pandemic. I can't speak to how they're going to handle retirees. That's not sort of my wheelhouse, but I do think that everyone learned from the crisis, and they learned about their own leadership style, and they learned what worked and what didn't work. And I hope that that will carry over into how they move forward in dealing with whether it's employees with long-term mental health issues, which is my concern, house staff with long-term mental health issues or late developing mental health issues, as well as people retiring or leaving the field maybe early because of what they went through. But, you know, they say that applications to healthcare programs are up, so maybe we'll get a new influx of people as well. Hopefully the lessons that we've talked about here today, the lessons of crisis management, the lessons of equity, will be what drive our leaders going forward.
I was just going to say, Lori, that one of the things that I learned through the process is not everyone's equipped to lead in a crisis. And while what I said was the same leadership skills in outside of a crisis and in a crisis, but it's just so much more intense. And maybe it is that resiliency that you have to be able to have in the middle of a crisis, or maybe you kind of hide when you're not in a crisis, and maintenance is you can perform and sort of maintain. But, you know, we did have some turnover during the period of time from our leaders. And then we had some people just completely rise up, and they weren't necessarily the people that you would have expected to either turn and not succeed or to rise up. But it really highlighted the strength of their leadership skills.
And this isn't maybe, again, directly answering the question about retirement and that aspect. But I will say that one thing I've observed within our own organization is another inequality that has been highlighted in the pandemic is gender inequalities and caregiving responsibilities. And I think it already is and will be even harder for employees to pretend that, for employers to pretend that their employees do not also have, caregiving responsibilities, and that can impact their ability to do their job and to show up for work. And so I think that is an ongoing pressure. I think it will be interesting to see both at a national level in terms of paid leave and the way we sort of thinking about that. But I think the pandemic really brought that need to light.
Yeah, I'd just like to climb onto that statement, elevated. I think that the long COVID question and the inequities those questions are still out there, and it remains to be seen whether or not employers are going to be providing the kinds of protections for people who suffer from long COVID. And again, because of the inequities of how the pandemic has played out, the groups from individuals from underserved, historically underserved groups are going to be those groups that are disadvantaged by a lack of protections in the workplace with regard to COVID. So the long COVID question is out there. I think that's something that now there could be efforts to really promote in terms of protecting people as they continue to experience the effects of the illness.
Thank you. I know we're running, we maybe have a little bit more time. Karen, I don't know if you have one more question for the panel or if you want to give them time to.
Sure, I can do either. You want to give the panel more time, or I could ask a question. What's the? Well, okay, so Dr. Cohen, I'd like to ask you about, you made reference to the traumatization of staff, and I'm wondering if you could just elaborate briefly about the particular distinctions in terms of the traumatization of staff that you referred to earlier during your presentation.
Yeah, I think, we've all learned about secondary trauma when we're seeing difficult things. And what I noticed in myself and in my team was that everybody had a different pattern of coping with the anxiety, the worry about their own wellness or health, whether the health of their families, and even for palliative care doctors that work and nurses and social workers and chaplains, we all in palliative care, we deal with a lot of death and dying, but that still doesn't prepare you for what we saw. So I'll give you one example of my own. I had a day where I was going to leave early for my own health issue, and I went downstairs to the ICU to just tie up some loose ends. I turned a corner and saw a gurney with an expired patient coming toward me with 3 men in hazmat suits, full hazmat suits, walking the body toward me. I didn't have my PPE on because I wasn't in a patient room. So I turned to avert that for my own safety. And when I turned, I was met with another gurney with a dead patient coming toward me. I turned another corner to get to my patient's room to meet the family member, and the patient's family member wasn't there, and my patient had died. So I encountered, literally physically coming at me, 3 corpses in a matter of about 15 seconds or 20 seconds. This is not normal. This is not normal. This is not normal in healthcare. This is not normal anywhere. This is just not normal. This was, traumatizing, and how we all coped with it and when we cope with it is different for everybody. I had staff that refused to come in and were panicking in the very beginning when we were like all hands on deck. And I had other people who, after it was all over, needed to take time away for their own mental health. And I have other people who are really just now working through it. And that's on a team of 10 people. So magnify that by a hospital, by a system, by a country. People are traumatized. They saw things they don't normally see. And that's just one little snippet of a moment. Imagine, several family members. I was struck by Ebony's slides about Latino patients, because our ICU was all Latin men, the whole thing. And we were coming to the realization that there were family members next to each other that teams didn't even know because they weren't caring for all of those patients. They might be caring for one, but as palliative care, we were recognizing this. So just recognizing the loss in that our families were suffering with, we were feeling that too. Or some of the losses that were just, felt more impactful to us because they reminded us of someone. All the things that we normally deal with in palliative care, but magnified 1,000 times. So we have to think as a system how we're going to care for our healthcare workers going forward, because this didn't just go away. This is going to also be a long haul.
Thank you. Thank you very much.
Susan, thank you for that, and for everybody on the panel. That brings us to time today. So we're going to spend a few minutes reflecting on what we've heard over the last 3 hours and talking about where we will head in the second and third webinar of this series. I think we've heard so many testimonials, as Susan just gave, to the fear and uncertainty and chaos of the early days of the pandemic, and also the power of teams that are motivated by love and vocation and camaraderie to pull off incredible things. And our speakers have given us a window into the lived experience of health professionals and patients and families during the pandemic. We have heard about what it takes to navigate uncertainty and be resilient as a US health system and as teams and as individuals, how to be learning and iterating as we go, and how crucial strong leadership is to making that possible. We've heard how the quick innovation of palliative care and hospice teams made a really meaningful difference in the experiences of patients with COVID and their families, and was critical to healthcare organizations' ability to meet the moment. And our presenters have also highlighted gaps in care for patients with serious illness. And a lot of these gaps existed before the pandemic, but were exacerbated by the pandemic. Chief among these being the glaring disparities in the experiences and outcomes of Black and Brown communities during COVID. And in our third webinar, we'll be hoping to synthesize promising opportunities to address these gaps in high quality serious illness care. In our next webinar, we'll focus on 2 topics where we've done a lot of rapid learning during COVID and that have been very much discussed today, because we have a lot of work to do building long-term strategies around them as we look beyond COVID. And these topics are telehealth and the strain on our workforce. Susan, I'd love to pass it to you for your closing reflections.
Thank you, Bryn, for your incisive remarks. It was such a pleasure to hear from you and our other speakers. We learned from Dr. Feinberg how leadership, science, public trust, preparedness, and strategic response are required for recovery. And Dr. Carroll's acronym for change is a constant: communication, hope, advocacy, nurture, a focus on the greater good, and empowerment as mechanisms to support our workforce, patients, and families. The first panel described how virtual platforms help us be more patient-centered, the value of team-based care, the need for interprofessional training, the critical role of palliative care as a specialty, and also as a skill set among our clinicians. COVID exposed health inequities and deficiencies that can be addressed by increasing value-based payment and attention to social determinants of health. The second session provided some remarkable innovations such as enhanced home care, a children's hospital managing adult patients, proactive outreach, Code Lavender, an inpatient COVID hospice unit, Patch 24 for ED palliative care, and the critical role that safety net hospitals serve in the community. In summary, adaptability to crisis demands interdependence of health systems and departments, routine communication, telehealth, community engagement, creative staffing, intentional inclusion of non-physician team members, hospital partnerships with public health and places of worship, and recognition that to address inequity, we need to build a lens around feasibility of health interventions beyond just access alone. With that, Bryn and I want to express our gratitude for each of today's speakers, moderators, and attendees, to our planning committee and the incredible team at the National Academies that makes this all possible. Please register for our next session on November 18th. We look forward to seeing you again. The video recording for today's event will be archived on the website. Bye for now. Thank you all.